Yep, I've just put it on now, Paul.
Great, thanks very much. So welcome everyone. This is our public governing body meeting. It's not live, but it is recorded and therefore will be available for members of the public to view via our website. And just a reminder, as usual, to our governing body team that we conduct ourselves in a way that is in keeping with our professional position. Before we come to some of the formal elements, we always like to start with a focus on what it and a reminder of what it means to be either a patient of one of our services or a member of a public in the environment in which we operate. And I'm really pleased that Julia Boas from the Intercom Trust and Darren Hapax from VCSE are here to be with us for this first part. Thank you. I won't go around and introduce everyone, but just so you're aware, we are a mixture of non-executives, clinicians, including GPs, nurses, hospital consultants, and allied health professionals, and social workers, and also the executive teams within the CCG. So a mixed bunch, but I promise you a friendly bunch. So Charlotte, did you want to introduce these next few minutes?
Thanks, Paul. I think you've done most of the introductions of who's here, but I just wanted to say often we do ask if we'll have patient experience directly from patients, but I think Julia wanted to share on behalf of people that they work with for reasons that I'm sure she'll talk about, just because often we do ask patients to come and share directly, because I know we like to hear from patients, and obviously Julia works for the Intercom Trust, so I won't take any more time and we'll hand it over to Julia and we can have questions afterwards.
Okay, thank you. Yes, and yes, as Charlotte said, we did think about asking some service users to come and talk, but as you may be aware, I think particularly within LGBT communities, people can be aware that that really does mean putting themselves in a potentially vulnerable position, and particularly at the moment, it feels like we are unable to be in person in supporting that. So it feels like the most ethical way forwards is for me to relay a bit of our experiences, and hopefully have some time for some questions after that. So just quickly, yes, I'm Julia Boas. I'm Deputy Director of the Intercom Trust. So we provide specific LGBT plus support across Devon and Cornwall. So we cover the whole of Devon, and some of that support is emotional support, but also advocacy work. So we work with people who want us to advocate on their behalves with organisations, including healthcare, to try and improve access. And so what I thought, I'm aware that I get like 10 minutes, don't I? So this is the moment I get to put as much info across as I can with a bit of patient experience. I'm hoping that you're all aware that for LGBT plus individuals, there are still barriers to access when it comes to healthcare. Certainly a relatively recent survey said that about 1/5 of people are not out to their healthcare providers, and about 1 in 7 have actually avoided accessing healthcare for fear of discrimination. Now, sometimes that fear of discrimination is imagined. It's that they believe that they may face some discrimination and do not feel up to it. At other times, it's a fear that is bred from their own experiences. And certainly, I think it's worthwhile being aware that particularly for older generations, some of our clients have lived through being criminalised, being pathologised, and are only now just reaching a position where they have certain freedoms, and so can therefore feel that much more private and potentially sometimes quite sensitive about how physicians, for example, will work with them. Sometimes that discrimination can be overt and obvious. Other times, I think it's often unintentional, and it often comes about from the systems being set up with these sort of heteronormative assumptions that can be made. So I'm going to try and give you a couple of examples of that to bring it to life a bit, and hopefully then we'll be able to take a couple of questions at the end. I should also kind of point out that there is a duty under the Equality Act to meet the needs of LGBT service users, and therefore this is something that is worthwhile trying to incorporate into practice wherever possible. So a couple of examples that some of our service users have experienced recently. One is of a trans man who I'm going to call Fred. Fred ended up waking up in hospital after an overdose. And the overdose was following, I should say, a particularly traumatic transphobic assault. Fred woke up in hospital in a female ward, and tried to say to the nurse, "I'm in. I should be in the male ward." To which the nurse responded that that he didn't want to be in a ward with all the other stinky men. And so, being rather vulnerable at the time, he stayed where he was, and only came forwards to us afterwards, where we were able to help him to go through the process of making a complaint about this. As you can imagine, for someone who is trans and is facing discrimination in the outside world, to then wake up in the safe space and be misgendered from the start is actually almost re-traumatizing for that person. And I think it's kind of obvious that that was a clear error on the part of the hospital. The good news on that one is that following the complaint, actually it was dealt with really well, and he felt that he had been heard and that the hospital had changed their practices. From my perspective, in this day and age, there's no need for that to have happened in the first place anyway. I would have thought there is the awareness there. I'm glad that that was able to move forwards, but it's a clear example of where we can go wrong. I'll give you another example of a gay woman we shall call Heather. Now, she recently had a relapse in her mental health, some crisis mental health interventions, trying to get on certain medications. And the medication many of you might be aware of is sodium valproate, where it's people are not allowed to be on it if they are of childbearing age, unless you go through a whole process that points out why you're not at risk of pregnancy. Now, from her perspective, as a gay woman, to be asked about reassuring them that she would have a contraceptive implant, or to have some way of reassuring them that she wasn't going to get pregnant, was actually, it sort of, I'm going to say it got her back up, and ended up with her disengaging with the mental health treatment that she really desperately needed at the time, because there wasn't the sensitivity when approaching the need, and I understand there's a clinical need to ensure that there isn't pregnancy. The trouble is the heteronormative approach. It's very heterosexual, the assumptions that are made about how people must be using contraception in order to not be getting pregnant, and to say, no, actually I'm gay was not sufficient. To say I'm gay and in a relationship long term with a woman was not sufficient. And she said that the consultant needed persuading. And that's what the consultant said. They wanted to be persuaded that she wasn't in danger of pregnancy. These sort of things, these sort of what can appear to be not massive things, can really push the buttons of individuals who, for some much of their lives, has been spent battling to recognise and honour their identities. And can be a real difficulty in terms of turning people away from a service that they desperately need. And if we're saying that sort of 1 in 7 people are not accessing a service that they need because they fear discrimination, you can see the sort of moments that really contribute to that, and that these can really add up. And of course, you know, I think there's been great progress in this past bit of time. I think we are making great moves forwards, and often it's down to individuals, it seems, in terms of how much they've learnt about subjects, how aware they are about things. But there really is a duty now to get aware and to make sure that your teams and your staff are aware of ways of sensitively working with people who are LGBT, and making sure that they do feel that they can engage in services and feel understood. I'm going to leave you, I'm really aware of the time, I'm trying to like cram everything in. Some of the things we're often encountering at the moment as well are problems that young people are having. Young people who are gender variant go to the GP and say, I'm trans and I want to do something about it. Some have been sent away because the GP has told them there's no service for them until they're 18, which of course isn't true. Some people have been told to go away and think about it a bit more and then come back to them, as opposed to looking at the simple pathway towards a referral for specialist treatment. Often people haven't gone to the GP as their first port of call. That's something that's happened after months, if not years, of wrangling with their own identity and thinking very hard about what they want to do. And so to be dismissed or turned away at that point can be just incredibly harmful. So yes, just kind of being able to have that openness about what the referral pathways are, what things are open to people, and how to treat everyone. I guess it's that dignity and respect element again. Yes, that, I think I really tried to keep it brief. I think that sums up everything I tried to say. I'm really happy to take any questions, queries or comments as well.
Thanks, Julia. That was a really, really interesting and moving insight. So I'll just open it up to questions for everyone now. Simon.
That was really helpful and really interesting. Thank you so much. I'm a GP in East Devon, and we're doing weeks. We're following the national themes around veterans and carers, and we've done domestic violence. And it would be lovely to have a week where we're theming on LGBT themes. But we're also doing some in-house training via Zoom and Teams for our staff, and I would love to invite you to come maybe one afternoon onto a Teams call like this to do some training for my staff, if that would be of interest.
Yes, I mean, that sounds wonderful, and training is something I'm a massive fan of. I think in our goal, you know, an organisation like ours should have only needed to exist up until about 10 years ago. It's a shame we still have to. So there's a level of wanting to get to sure that all services are welcoming to everyone, that we don't need the specialist services. As a small charity, I'm afraid we do often have to be quite careful about our time, but we do have small training packages, and we do have the capacity to come in and do training with teams and make sure that we're able to help other services to get their practice to where they want it to be. So yes, please do. I think I'll put my contact detail in the chat. Send me an email and we can have a chat about it.
Julia, that's great.
Great, thank you.
Do you want to come in?
So Julia, thank you. It's, you know, you said right at the beginning that actually often it's not the individual, it's the environment in which they work in that can often promote some of these biases. And I wonder if you went back to that psychiatrist and challenged him about the impact he had, there may well it may well be quite an eye-opener to him rather than something that he was expecting. And I can understand there are things around. So the sodium valproate, that's an example where actually people's priority as a clinician is a potential future baby and litigation and all of those sort of things, particularly because the regulators come down very hard line about those sort of things. And I guess there are some things where the top-down regulation and expectation, and therefore the defensive medicine, get in the way of some of those more sensitive conversations that could be had. I don't necessarily have an answer to that, but I can certainly see that playing out in more than one situation where we as clinicians have, you know, are the patient-facing contact of that sort of top-down approach, and that defensive approach often we have to experience, and therefore, you know, our patients experience in a particular way.
I think it's such a good point, and I think many of the systems have been designed simply without LGBT people in mind. And so there's a level of understanding that as clinicians, you have to think about risk and you have to think about potential litigation. Often from my perspective, it's how it's put across. It can be sensitively communicated in a manner where we sort of say, I'm sorry, there's this boring form that we have to fill out so that we can just get the paperwork done. Or there's that moment of sort of, right, I need you to persuade me that you're definitely 100% gay. Now, that one is offensive and one is perfectly sort of reasonable. So I think there are ways around it. But I also do think if we can work our way up the chain to create systems that are more, that incorporate more diverse identities, then we prevent it being so off-putting in the first place, or putting you in that awkward position. Yeah.
Sheila.
Yeah, thank you, Charlotte. Thank you, Julia. I enjoyed your little talk. I wish you had longer. My name's Sheila McCormick. I'm a GP also from the western part of our patch, so based in Plymouth. I guess I just really wanted to respond to what Paul said, because whilst I agree what he said, but actually if we go back to the principles of informed consent, any patient, whether they are LGBT or anything, any patient at all, just needs to have the information they need, and then they can make that decision. And so, to my mind, just having that conversation with the patient and recording that, that is that what you've said, and that the patient has that understanding. Should be enough. And sadly, Paul's right, there often is a lot more blame that's put on us, and that leads us to not allow allow patients to take their full responsibility for themselves, which is a real shame, I think.
Yeah, totally agree. Yes. Yeah.
Graham.
Thank you, Julia. I'm not a GP, I'm a layperson, and I'm afraid I've got a question that might put you on the spot, so I apologise in advance. But one of my responsibilities as a layperson is to chair a committee that looks at equality, diversion and inclusion issues, and I work with a host of other people who are here today who do that. So your two examples were very powerful and really made me think. Could you bring to mind an example about perhaps an NHS body as an employer? So rather, your examples were about service users and their interface with the service. Can you bring to mind an example about how an employer might make some heteronormative assumptions and affect its employees?
Ooh, that is an interesting one. Yes, you have put me on the spot. Well done. I like that. That's okay. So what you're talking about is where the employer themselves have set up systems and processes.
Yes, it might affect its employees who might have not declared their situation.
Yes, I mean, I think one of the difficulties a lot of people have encountered are things particularly around gender identity. So finding out, particularly when an individual is trans, looking at how that is recorded, how it is managed in line with the duty of confidence that comes with the protected characteristic. So sort of not accidentally outing people is one element. I know this isn't an NHS employer, but I do know of an employer who changed their systems where marital status, for example, was part of one of the things they recorded. And because they recorded civil partnership separately to marriage, certainly before the law changed to enable heterosexual civil partnership, that was a way of outing their members of staff without intending to. I think one of the main things we have encountered when people have difficulties with employers, it is often a lack of understanding. And often it's come down to employers not taking their responsibility to challenge prejudice and bullying that can occur in the workplace itself. So it's when other members of staff, for example, decide that it's quite funny that they can make a joke about somebody, and actually what happens is that the employer takes that as, oh, it's all a bit of banter and it's all a bit of fun, without kind of realizing the desperate impact that it has on the employee in question, and not kind of adhering to their responsibility to challenge that. Sorry, I'm not giving you real specifics right now.
That's been really helpful, Julia, and I'm going to look at Andrew now, perhaps put Andrew on the spot. And Andrew is our director responsible for these issues. Andrew, you might want to think along the lines that Simon did, whether Julia's organisation could provide some training for us, either to the group that's looking at these issues or more widely, and bearing in mind the fact that this is a charity, that we could no doubt make suitable arrangements for that time to be provided in an appropriate way. But I just leave that with you, not
we could, Graham, and hi Julia, Andrew. I think we've certainly started some work around diversity issues ourselves as an employer, but that's been largely around the BAME community, which has been really enlightening for us about some of the things that we don't do for our staff, and indeed some of the things that we need to think about from a patient and public point of view. But I'd love you if you could actually perhaps think of something that you could do to support us if we were to take some work forward around the LGBT community. And I think we certainly could put some arrangement in place to do that if you would be happy to do that.
Yeah, very much so. Yes, absolutely. Yes, please do get in touch.
Okay,
Yeah.
we will do.
Sure.
We've got James and then Alison and then Sheila.
Thank you, Charlotte. Thank you, Julia. And my name's James Wooldridge. I'm another lay member like Graham, and I have a special interest in mental health. And in my other world, I run Recovery Devon, which is a small community interest company here in Devon. My question refers right back at the start when you mentioned what a challenge it is to get someone from the LGBTQ+ community to speak to a group like us. And I understand that, we face the same challenges with mental health and people sharing their experiences. But I wonder what you feel we can do either as a governing body or as a group to kind of create the safe space where people would feel able to share, and also to see it as an opportunity, because we love to hear from them, and we love to hear from anyone, but we want to create an atmosphere where people feel welcomed and supported to share their experiences.
That's a really good thought. I'm trying to think of what I think would make a big difference. I think for some, and I'm sure this is true of many service users, there's a level of intimidation with speaking to a large group of people. I think sometimes that could be overcome by, for example, having a pre-recorded video, which they can sort of runs through their experience. And I mean, it does mean less questions, but it may be that they're then able to answer some questions. Something about maintaining the confidentiality of it. So to know that one is speaking to a defined group of individuals, and for example, not that it might be posted online as one of the major meetings, so that there's a bit more control as to who's getting that information and who isn't. I think that can make a big difference as well, so that it can be, we can offer some reassurance that this thing will be shown to this group of people only, and that they will then have an opportunity to ask some questions following that. I think both those things can make a difference. And sometimes it's quite nice if somebody is outing themselves to speak to a group, if the group can out themselves in return. So a level of feeling like they aren't just talking to an anonymous group of presumed straight white faces. Can be, I think, quite a useful one. So the more diversity there is in the audience, I think that does help people as well.
Yeah. Thank you, Julia. And I'm quite happy to out myself as someone who takes sodium valproate. So.
Okay. Yes. Yeah. Exactly. Thank you.
Thank you, Alison.
Yeah, it was partly in response to Graham, because I know he put Julia on the spot a bit, asking what we could do for staff. And it was just an observation by me when I was at a hospital in the recent weeks that they'd put temporary shower blocks outside, presumably for COVID, marked male and female. And it registered with me at the time that someone hadn't thought that through. And I just wondered what Julia would say about that.
Yes, absolutely. I mean, actually, in general, I find this male-female lose thing slightly odd. We don't have that in our homes. I don't know why we have to have it in public. I think we're all civilized human beings that are able to manage ourselves, particularly when there are cubicles. I can understand, you know, a line of urinals maybe, but yes. So having the explicit signage where there are people who are non-binary, for example, so who don't identify as male or female, and making sure that there is availability to everyone, I think is crucial. And it's funny, us LGBT folk, we look out for the little signs. We look out for the posters, for the little stickers, for the things that tell us that people have thought these things through. And that's immensely reassuring when you encounter something which feels like, okay, no, they've thought about the LGBT community in some way, shape or form. Suddenly it enables one to relax a little bit more. And so I think, yes, it's where we encounter these particularly binary assumptions now, that it can be so off-putting for other people and puts people in a very awkward position. It's not that difficult to overcome, I don't think.
Thank you.
Thank you. Yeah.
Thanks, Sheila.
Yeah, thanks, Charlotte. So I actually was also going to respond to Graham and answer his question to you, Julia, which is along similar lines. So NHS England in the staff survey, and you might remember that I raised this at REMCOM a few months ago, only asks staff whether they identify as male or female. Those are the only two options. And we are way behind as a country in this. In Australia, you are able to identify yourself as other on your passport and have done for probably 5 years now, I think. So we are still very behind in this country. It's not that difficult, as Julia says.
Yeah.
Thank you. Well, I think that's all the questions, and we're probably coming to the end of our time. I just want to really thank you, Julia, for taking the time to talk to us. You definitely don't need to apologise for charging for services. That's a whole nother session, but you definitely don't need to apologise for that. Yeah. And we really, really appreciate you taking the time and sharing the experiences that you gather from people you work with. And thank you to Darren as well for sort of bringing you in and organising this. So yeah, thank you. And I know you're going to put your details up.
Yes, I've just done that. So thank you all so much for listening. Yes, I appreciate it. Yeah.
Thanks, Julia.
Thank you. Brilliant.
Thank you, Julia.
Thank you.
Great. Thank you, and thank you for bringing that for us, Charlotte. And certainly, you know, Andrew, I know you've taken away some plans on how we can use this as a stimulus for us to address not only for our organisation but also for our public and patient engagement, and how we can enhance that in the same way that, as you say, we've done with the BAME. Thank you very much. Thank you all.
Paul.
Yeah.
Can I just chip in there, because I raised I mentioned that I'd raised the question about binary identification on the staff survey, and Andrew, you weren't at the meeting, but Piers was, and I feel that we ought to be escalating this to NHS England, because you know this is an opportunity to influence for the better. Why wouldn't we take it? Yeah. I hope it is an opportunity anyway. I can't see how it would detract from our reputation. It's a positive thing.
Yeah, I'll check with him, Sheila, where he's got to, but I'm happy to personally do that, because I agree with you completely that we should not be in the dark ages, should we? We should be at the forefront. So I'm happy to feed that back.
Thank you. Sorry, Paul.
No, that's fair enough. Fair enough, Sheila. Thanks very much. Okay, so we go on to item 2, which is welcome and apologies. So again, I'm just seeing if Steve is still with us. I can't see him on the list, so as and when he joins us, I will again in public formally welcome him as part of the governing body. But I do have apologies for Caroline Diamond, but that's the only formal apology that I have. We don't have any questions from the public, so it's to the register of interests and any additions or alterations that people need to make to that register. And Sheila.
Yes, Paul, just as before, that I'm now being seconded into the role of mental health clinical lead for the CCG.
Okay. Thanks very much, Sheila, and we'll make sure that it reflects that in future iterations. And any declarations that you need to make that are relevant to items on the agenda? No, so that's good. Okay, so we then go on to the minutes, and I will take the minutes as the page numbers of the minutes rather than the overall page numbers. It makes it easier for people to follow, I think. So we start with page 1 and 2. This is for accuracy. 3 and 4. 5 and 6. 7 and 8. 9, 10 and 11.
10.
So, Julie?
Yeah, can I make a correction on page 10? Section 15, third line, on a quality assurance early warning system when a practice is closed, should read when a practice is at risk of being closed.
Okay, right. Nikki will make sure we get that altered.
Thank you.
So with that alteration, we are happy that that reflects, that's an accurate representation of our discussions last month. So that then takes us to the action log. We've got 2 actions, both recommended for closure. The first one was for Joe, which was investigating the reasons why IAPT recovery rates have deteriorated in Livewell. And we've got here from last week, the mental health team provided a rationale as to the variable recovery rates, and the team are going to monitor closely to ensure this does not happen again. Joe, can I just ask, they may have provided a rationale. Is that rationale reasonable and sufficient?
Yeah, I'll give you just very quickly. So the rationale, so this was when we went into COVID wave 1, so they changed the way, just in order to try and support the amount of people and try and free up capacity, they slightly changed the way that they were providing the service. They were doing it over a shorter period of time, which meant people weren't achieving the recovery rate. They very quickly though reviewed that, and they've gone back to what we would say is the acceptable, the accepted way of delivering that service, and actually performance is back where we would expect it to be. But what I have asked the team to do is just keep an eye on that over the next few months, just to make sure there are no further issues with that service, particularly as we move into wave 2.
And when would we expect that recovery rates to return to normal, or to return to previous?
Yeah, so they are, and that's the latest information says that they are now, but we will keep an eye on it over the next few months, particularly, as I said, now that wave 2 has stepped up and we know might have issues with sickness, etc. We will keep a close eye on performance.
Okay, thank you. And then the other item is item 2, which is again for closure, which was around our health and safety policy. What we issued with regards to use of mobiles whilst driving. Ginny, that's been clarified within the document, has it?
Yeah, so we checked back against the HSE guidance to make sure we were in line with that. I think the issue was that just before our last governing body, there had been a call by MPs to review that HSE guidance and for further research, but that hasn't actually changed the guidance yet. So we're happy that we are in line with what we need to be.
Right, okay. Thank you very much. Okay. And that's our actions then, both for closure. So that then takes us on to the chair's report, and I will take that as read. The only bit that I said that I would provide a verbal update on was around the system lead executive and a CCG accountable officer recruitment. And just to say that we went through the interview process last week, and we are at a point where we would like to recommend a particular candidate, and we are waiting confirmation from NHS England that meets with their approval. And once we have that confirmation, we can then start making plans, and obviously we will be hopefully making a formal announcement at that stage. So the process is proceeding and proceeding well, and we are optimistic of a positive outcome. So any questions on that report? Then I will hand straight over to Simon for the Accountable Officers report.
Thanks, Paul. So I'll do the same and say the report is as read. Happy to take any questions. I think probably appropriate for obviously COVID position is moving very, very quickly. So whatever I wrote a week or so ago is now out of date. But as of today, we've got 250 people in beds with COVID, of which 18 of those are in our ICU, and as I've reported before, the Nightingale Hospital in Exeter will be taking its first patients today, transferred from the RD&E. But I don't know whether I could ask Sonia just to give any more detail that she thinks is pertinent at the moment.
Okay, thank you. Yes, so as you reported, we are increases in COVID that exceed wave 1, and of course this is our first COVID winter, so the competing pressures on our capacity to manage winter pressures, COVID, and obviously the services we are providing for our population continues. I think I wanted to recognise how hard teams are working in all our services, both within the CCG and within our providers and partners. And it's probably fair to say, although we have seen a slight impact of the national lockdown in terms of some of those case rates and some of the COVID prevalence, it continues to be a huge pressure. We are managing that, and we're balancing the risks. The main thing I just really wanted to echo is that we are working really hard on that, and wanted to really recognise all the efforts that our provider staff particularly are providing in that.
Thanks, Sonia. So happy to take questions, Paul. So I think there's a couple of hands.
Yes, Simon first.
Yeah, thanks, Simon. I just wanted in public to ask you for assurance about what we're doing to keep the sort of non-COVID work going, particularly in Eastern Devon, and particularly knowing the pressures in the hospital there with the COVID work. What can we say about what's going on to help make sure people can get access to all the non-COVID services as they would normally expect?
Yeah, so Jane Carroll may wish to talk about that. So obviously we're using the independent sector, Simon, quite heavily to make sure that we can delineate really appropriately in terms of planned care from urgent care. It has been a real challenge. There is some mutual aid going on between hospitals too. One of the biggest issues we've got is staff sickness, which has been particularly prevalent in Eastern, and the lateral flow testing will help us with that. There was and just as a particular example of mutual aid, there was a particular shortfall in RD&E that their pallet delivery was less and later than they were expecting, and DPT lent a good proportion of their testing kits over to the RD&E to make sure, because that's where the pressure was. So it is tight, but we've obviously got all the infection control measures in place. There are more virtual clinics, etc., ongoing, but it would be wrong to say that we are fulfilling all of our commitments or trajectories that we made in the phase 3 return, because as we reported earlier, there's been quite a lot of cancellations, particularly in Eastern.
Do we know whether the opening of the Nightingale will have some effect on that?
It will clear out some of the, so the real issue we've had, Simon, is not just the sheer number of COVID patients. So there've been about, so at the moment it's about 116, I think it is, in the RD&E, but it's the number of beds that have had to be shut in association with that. So having patients decanted to the Nightingale will free up more than just the beds of the patients that they were in. So I think we're transferring, I think it's 8 today, but 48 over the course of the next week or so will free up more than 48 beds.
Thank you.
Great. I can't see any other hands. Graham.
Thank you, Simon, for your report. I wanted to ask you a question about section 3, which is on integrated care system planning. and I suspect that's moving almost as quickly as COVID. Your report says that a draft submission will be submitted to NHS England in December. Can you just outline for us who will be signing off that submission? Is it the Integrated Care Partnership Board? And if it is, will this governing body have any sight of it before it goes?
Yes, Graham. So yes, you're right in your assumption. It will be the partnership board, and myself and colleague chief execs have requested the same paperwork goes to all of the governing bodies and boards of the sovereign organisations. Whether the timing works for everybody to see it before the submission, because it's not complete yet, I can tell you that much for certain. We're not sure, but the final submission goes in January, so we will at least have a chance between the first of the draft submission and the final submission to have a contribution at this governing body.
Thank you, Simon.
And Graham, just to add to that, the system chairs discussed with Susie and were very clear that they would want system board sign off and approval of this submission before before the final submission. And so that has been discussed to make sure that it does go all to the boards, including the governing body of the NHS organisations.
Thank you, Paul. That's really helpful.
And it will come. So I've been told by Susie that it will be ready to come to our December governing body. Nick.
So it's just a very small point, really, just around the Nightingale. I don't know if Simon can answer it or someone else. Presumably, all the transfers of patients isn't going to negatively impact on the ambulance service, particularly. Has that all been worked out?
I'm sure Darren or Sonia can answer that, but yes, it's been discussed at quite a lot of length. But do you want to cover that, Sonia?
Yeah, so certainly in terms of patient transport, all those arrangements have been worked through for the various pathways to support the clinical model, but particularly, so for example, today, as patients start to arrive at the Nightingale, those are that's patient transport that's been booked over and above the existing expected COVID and non-COVID patient transport. So those arrangements have been put in place. That certainly shouldn't impact, and that's not ambulance trust transport.
Okay, thank you.
Okay, then thank you very much, Simon.
Glynis has got a hand up, Paul.
Sorry, I'm not getting up to date with the hands. There's a bit of a delay on my computer, so apologies. Thanks for pointing that out, Simon. Glynis.
Yeah, I just wanted to congratulate you on, Simon, on the staff awards, because although I wasn't able to join it, I've heard really good feedback, and I think it's indicative of a really inclusive and engaged culture. So well done.
Thank you, Glynis. I wasn't going to mention it too much because I thought I might get drawn into commentary about Paul's cooking skills, but yes, it was good. Thank you very much.
Some things will never be dropped, will they?
There's no more hands, Paul.
Thank you very much. Okay, in which case, thank you very much, Simon. That's a good note to leave the AO report on, it's. Jane for item 7.1 for the winter plan.
Thank you,
while you're doing the introduction, I'm very briefly going to log off and log on again to see if that helps me with the chairing and with the hand raising. So apologies if I lose you briefly.
Thank you. So you have in your pack the system draft winter plan for your approval today, and so I'll do some few words of introduction to the plan. Obviously reflects a system approach to our planning for winter. So obviously underpinning this document is a large volume of plans built on our locality, our provider plans, local authority plans, and as well as a range of specific programme plans, for example, our flu vaccination. So it's been an integral part of our phase 3 submission as well in the early days in September, where we were having to look at our demand and capacity. So this has been a plan of development over the last 2 to 3 months. And I think on that context, I just want to say a big thank you to all colleagues who have contributed and to develop those individual plans and to work together as a system to bring together this overarching system plan. And I think that's, for me, it is not just a document, obviously, it's embodying a way of working. It's in terms of how we work as a system, how we manage the challenges that we face this winter. It's been overseen and it's through its development by the System-Wide Urgent Care Programme Board that Penny chairs, and was supported, signed off last week at that meeting, following 2 reviews of previous earlier drafts. In terms of its approach, it builds on the learning from last winter, and also, of course, the learning from the first wave of the pandemic. Obviously, recognising that this winter is somewhat unique in terms of us having to balance our COVID pressures, our normal winter pressures, of course, as we've already touched on, as well as looking to maintain as much of our elective capacity in terms of our recovery as planned. And of course, take into account any implications, if they do occur, of the EU exit at the end of this calendar year. So within that, therefore, this plan is obviously of a different style and approach, because it's obviously having to respond to those particular pressure points, and obviously particularly into national requirements in relation to COVID response. But fundamentally, at its heart, it's about ensuring that we can respond to those additional pressures on services, and therefore we do not obviously therefore compromise in any way our safe and effective delivery of services in each of those areas. And that's going to be delivered through obviously operational at locality level, but of course through system working and system initiatives as well. In terms of the document, just to give you a bit of an overview of the sort of way we've laid it out, Section 3 sets out our response to COVID-19 in terms of testing, infection prevention control, personal protective equipment, outbreak management, and of course the plans to utilise Nightingale, which of course is now in use as of today. Section 4 sets out system-wide plans and initiatives, describes those, so notably a couple of those being, of course, our expansion of the 111 Thirst offer and delivery of the expanded flu programme, but also across a range of other areas as well. And importantly, in terms of, I would also want to note how we work with the voluntary sector. That's obviously been integral really in terms of the first wave pandemic, but also moving forward through this winter. Section 5 sets out the acute, including both COVID capacity, hospital capacity, and out of hospital capacity plans. And I think it's worth particularly noting on this that for this, thankfully for the first year, we've had a extensive piece of work done looking at our out of hospital capacity, aligned to the discharge to assess model, where we look at the capacity across particular pathways to support people to get to the right home environment and appropriate support to achieve the appropriate destination for them. And so that's been quite a big piece of work led by localities, and actually helped to inform and understand the gaps that we have in our capacity, and therefore what we need to put in place, whether that be in domiciliary support, whether that be in terms of residential or nursing home capacity. Section 6 overviews the locality plans. There are individual plans for each locality that particularly identify schemes, initiatives that have been brought in to provide additional capacity in each locality to address issues of capacity, or where we know there's good evidence in terms of impact over winter months. And Section 7 sets out the escalation and governance arrangements. We touched previously, we've got in place now a winter operations centre, which obviously is coordinating our response to the pressures of through this winter, as well as an escalation framework that we've developed that sits alongside this plan in supporting working as a system to make sure that we make appropriate risk-based decisions where required in escalation. And at the heart of that is really mutual aid working, as we've just referred to earlier. And Section 8 talks about enabling plans, but actually it's more than enabling, it's our fundamental plan around workforce. This plan is predicated, obviously, of course, on ensuring we have supported and enabled colleagues at the front line and supporting in terms of delivering our services. And obviously it's been a challenging year for all, and this pressures of the moment, and bearing in mind we're only at the start of winter, we know how we support our colleagues in terms of their resilience, their well-being is fundamental. So there's some of the initiatives are described in that section there. And similarly, also another important enabler is our communications. And for the initiatives around flu campaign, for 111 expansion, making sure we are appropriately, effectively communicating to the public is really key. And there's some very good work described there that's underway, building on learning from the past as well as elsewhere. So some really good work there. And section 9 really talks about the risks and arrangements for monitoring. So we'll be obviously looking to review our progress, particularly on the delivery of the initiatives at local or system-wide level through the Urgent Care Programme Board on a monthly basis. And we've identified here a summary of the risks in the document, which obviously also will be taking stock on. Obviously, fundamentally, we've summarised the major risks, as I've said already, a workforce particularly, both not only in terms of resilience, obviously sickness, isolation, all of that in terms of making sure that we've got adequate workforce, obviously is fundamental. And importantly, of course, therefore, it's balancing our capacity, both staffed and physical capacity, in responding to peaks of demand, both winter and COVID, and at all achieving, ensuring that we can still maintain our elective activity. And that's the challenge that we have to balance through these winter months. But there's mitigation set out in relation to those summary of risks that we've put in place there. And I think just finally to conclude, we've been through a assurance process with regional colleagues. Simon, with Chief Execs, was party to a meeting, I think a couple of weeks ago now, where it was particularly looking at our response in terms of demand and capacity and surge arrangements. We've been through a process earlier this week, after completing a large number of key lines of inquiry. And we await the formal sort of sign off of that process in terms of response, but we've had positive feedback. Particularly, the feedback has been that they've seen, and this is from the regional head of urgent care lead, who's also attended our last 2 urgent care boards. He's seen a big step change in our system working, in the development of this plan and how we're working together, which I think is really good to note, and has used our plan to share as an example of good practice with other systems as well. So obviously, a plan is a plan. Delivering it is the fundamental aspect of work that we've got to now work on. Obviously, Nightingale opening today is positive in terms of a lot of hard work in bringing that online. But importantly here is how we work together as a system across all health and social care delivery, working with the voluntary sector and at local level and at system-wide. So I'll stop there, and obviously with the help of colleagues, happy to take any questions.
Can you see my hand up?
Yes. No, I can. Sorry, I went on and off mute several times. Penny had her hand up first, so we'll bring Penny in and then Gaynor.
I was just going to reiterate what Jane said as chair of the Urgent Care Board about the level of engagement in this process that's been very positive this year. Every representative at the board, and it's a very wide-ranging board, has confirmed taking winter plans through their own governing arrangements. And I think that level of engagement has been recognised. As Jane said, we've got the head of the winter planning process from NHS EI with us at that meeting, and he's been very supportive of the work that's been done here. So I just wanted the board to be aware of that.
Thanks, Penny. Gaynor.
Yes, thank you, Chair. Jane, I just want to say that first of all, I'm in full support of the discharge to assess model and the admission avoidance work that's going on across the county, and because we all know the best place for the patient is at home. Obviously, with these initiatives coming in, because in some areas they are new, there has been a high demand for packages of care and domiciliary care. And I know that you've put that on the risk register as far as a mitigating risk. So I'm probably going to be micro-constructive comment is just to highlight that one of the things we might need to look at mitigating is those 2 weeks over Christmas. It is jolly hard to get packages of care normally. So with all these initiatives and obviously with COVID, I just wanted to just point that out.
Simon, did you want to come in?
Yeah, Simon.
Yeah, so thanks, Gaynor. So completely agree, and obviously we normally see close down in care home acceptance as well over those 2 weeks. So I think I reported previously we're in the process of recruiting some additional staff onto the NHS's books to be able to backfill some of the gaps we've got in personal care hours. So they will join things like the urgent community response in RD&E, and in West Devon they're joining Livewell Southwest as the equivalent of healthcare assistants to help support the personal care gaps. So I agree with you, it is always an issue, but we have got some better mitigation than we've had previously.
That's marvellous, brilliant, thank you.
And just before I'm going to bring Judy in, Graham's just put in the chat, and it's probably easier just to ask for clarification here, Jane. We're asked to approve this. Is the same thing happening with the other NHS organisation boards, so that all system boards will approve this plan?
Yeah.
I thought that would be a quick, straightforward one. Judy.
Suggesting mine won't be. I actually have two different questions. I'll pose them both, but they are different things. Firstly, thank you very much. This looks like a massively comprehensive piece of work, and I'm really pleased to hear that other systems are being shown it as a good example, because it's very important to know when we're doing well on things. It's not for me to understand the detail, but I do know that critical care beds are a key thing I watch in the measures, you know, when I look at the key measures. And I don't quite understand in section 5.14 and continuing how we move from starting saying we have 10 critical care beds and then ending up with a possible of 117. And I think that may be just that I don't understand green surge and amber surge. So I'm going to ask Jane to explain that.
Sure.
And then my other question is to do with the communications, and a question to Andrew, I guess. My understanding is Think 11 First is part of a national communication plan, and we're doing what the national plan is. But I'm a bit worried because last week I was on the primary care call when the national system forgot to tell GPs that they were going to announce the flu vaccine being available for 50 to 64-year-olds. And all these GPs were coming on in the chat box saying they've had calls all morning. So are we supplementing if we are concerned that national information is not sufficient for our local services? So sorry, it's two separate questions, but I thought better to ask both at once.
Yeah, do you want me to do the latter one, Jane, because it's fresh in mind? So yes, Judy, we do use the national materials, of course, but what we do locally is adapt them for our own needs, and we always keep a watching eye on whether we need to further adapt stuff as and when things happen. So yes, we do both.
Okay. And if I picked up the critical care one, and probably want to bring in Penny on this as well. And so in essence, what you've got in the diagram there, there's like the chart. It's reflecting the degrees of escalation. So what we have in terms of the green surge capacity, there was some additional capital money that we secured to expand ITU capacity. So if it come on board, it would give us more ITU. And where you move into amber surge is when basically you're moving into recovery space or theatres and utilising that. So it's what already happened when everyone geared up back in the first wave, where services were stood down because obviously the numbers were expected. So it's where you would go to that level. But of course, the consequences of that is you would impact your ability to undertake elective surgery.
Thank you, Jane. Nick Kennedy.
Thank you. Yeah, I've got a few questions. Yeah, Judy, that ITU thing, obviously in intensivists, I can confirm that's exactly what it is. It's escalating into theatres, recovery and other areas which largely have ventilators. It clearly then has an impact on staffing of beds and so on, but that's a whole different thing. But those numbers are realistic, I'm sure. So I've got three things. Firstly, the Think 111 staffing. can you give us assurance that you'll get it, that is going to be okay? Because clearly at the moment it's based on agency staff and you're trying to recruit and so on. But are we going to get to the point where that really is going to work? That's the first one. The second one is there's a whole lot of stuff about local testing, which is great, but is there any local test and trace, or are we relying on the national test and trace? I don't really understand that. And the third one is just a small point, but it's something that I've had a look through and I can't see anywhere. It's relating to paediatric mental health and the large number of large adolescents, but also younger children who are ending up in acute beds with mental health problems, causing a significant issue. And I can't see that addressed anywhere. I hope that it's something that is being looked into as part of the winter plan, because that will impact significantly on paediatric capacity.
Okay, I was going to say, does Joe want to pick up the 111 staffing question?
Yep. I'll pick that one up. Thank you, Jane. So just to let you know where we are then. So just in terms of getting ready for Think 111, the national launch on the 1st of December. So we've got programme board, so Think 111 programme board, which has been working up to the launch of the 1st of December. We've got a work stream within that, which is the demand and capacity planning work stream. They've been working, as I updated on in private, they've been working on the national modelling around demand and capacity, so expected demand from the 1st of December onwards, and what Devon doctors would need in terms of call handlers and clinical staff as well. They're on track to achieve that. In terms of achieving the call handlers, that will be permanent contracts. Don't have an issue with that, and like I say, they're on track. In terms of clinical, that is more challenging. So although actually they're not far short of where they need to be, the residual will be made up of agency locums in the short term. But we had a useful update at the board yesterday. So Piers Tetley, who's obviously our lead from a workforce point of view, has been leading that work stream for the Think 111 programme, and actually we think by offering employment contracts we will be able to make that more attractive to the clinical staff to fill those roles. So whilst on the 1st of December yes, there will be some agency, we think we can improve that moving forward, and we're fairly confident about that actually for the grades of which we need to have for those clinicians. So we're talking about 7s, 8As really, Nick.
Thank you.
And the point about the mental health, children's mental health, and obviously occasions where we have challenges in terms of children being mental health issues being on the paediatric wards, that not explicitly mentioned in the plan, but in effect it would be normal practice that would be, if that wasn't young person wasn't appropriately assessed by CAMS, and then obviously then the appropriate onward care put in place, that would be escalated through our normal local arrangements that exist in that regard, ultimately potentially coming through to ourselves to intervene and create and put in place a call between agencies to address if it was an issue that wasn't resolved.
Well, it's just that there's been quite a glut of it, and it has impacted on services, and with the projected significant increase in children's mental health issues as a result of COVID, I just wonder, that could cause a surge in problems. It's just something to be aware of.
No, it's a valid point, Nick.
So yeah, can I come in, Paul? Sorry. Yeah, so we've had two particular issues recently, Nick, one in Torbay and one in a facility run by Livewell in the Western system. And Darren and I have met with the DCSs to make sure that we are, Directors of Children's Services, to make sure that we are dealing with each individual as swiftly as we can to get them to the right place. The Torbay child has really unfortunately been placed in Edinburgh. So what Darren and I have agreed is that we will work with the Directors of Children's Services for all 3 local authorities in Devon and in Cornwall about what is the right facility that we can have in the peninsula to be able to deal with this. That's not going to help for this winter, but it is something that we've been discussing, in a really focused way with our colleagues in the local authorities.
Okay, thank you.
Okay. Thanks, Simon. David Greenwell.
Yes, so I was just really asking about imaging capacity. Does the opening of the Nightingale Hospital mean that we lose the imaging capacity that was in there, or can they run that at the same time as running the ward?
Okay, so I mean, I'll bring Darren in here on any of the detail, but we have agreed so that the capability of running the diagnostics such as CT, etc., is able to continue, but we have agreed to move the MR scanner down to UHP. That isn't because it can't be provided there, but because it makes more sense for the next few months to provide it at UHP because at Plymouth, because of the number of patients that are travelling at the moment from Plymouth to Exeter to be seen, the bulk are from that area. And it makes more logical sense, therefore, to put the mobile facility down in Derriford for the next few months, but we will review that. But Darren, do you want to add any more about the diagnostics?
No, just to say, Jane, so obviously with the Nightingale becoming COVID positive, we have lost the diagnostics capability there, so ultrasound has had to move out. And at this moment in time, we're not able to use the CT scanner, although we are working with NHS England to see if we can work through that process, because ultimately where the CT scanner is in the building doesn't make it easy, but I don't think that's insurmountable. But as Jane's already alluded to, the MRI scanner would have run anyway, but due to the right population need, that has already been moved to Plymouth as of last week.
So I think what you're saying is we don't lose any MRI capacity,
no.
And we're able to use the ultrasound capacity at a different site, but we do lose the CT capacity.
So we've lost the CT capacity and we've lost the additional ultrasound capacity from the Nightingale that hasn't been repurposed elsewhere at the moment. So we have lost ultrasound and CT.
I presume it's completely mobile, so it could be.
Yes, it could be.
Okay.
All right. Okay. Thanks, Darren. Simon Kerr.
Thanks, Paul. Jane, I think it's really good to have a winter plan with everybody's contributions from all the way across Devon. First time I think we've done this, and it's really good to have that all in one document, so well done. I think we need to make more of the workforce issue and the workforce resilience issue. You know, we're really struggling in provider land to keep things going. We've had almost like 3 continuous winters already, and you know, we're being thrown more money, which is lovely, but actually it's just the same old people working more and more hours, getting more and more tired, and frankly getting some people getting quite unwell. So I just think I'd like to see more in there about what's the reality on the ground and what's the trajectory, planning to keep people well, keep people able to keep going. Because you know, it's the thing that worries me more than anything, actually, in terms of delivering winter.
And it may well be, it might be that we could keep that absolute spotlight on that fundamental agenda through the monthly meetings of the Devon Urgent Care Board. I'm just thinking, Penny, because we want to be, in terms of where we're looking at issues and making sure that we've got in place as a system all the arrangements that we can potentially put in to obviously support workforce all the way through. But I agree, it's the number one. And I think the recent weeks of the challenges in the hospitals and obviously staff having to isolate have really shown that.
Yeah, I'm very happy with that, Jane, and also very clear that the workforce issues are one of the biggest risk issues that would go through the dynamic decision-making group as one of the reasons we might move into escalation. And it's one of the most important risks we identified in that process too.
Mm-hmm.
And I think, Simon, on that, every sort of national sort of meeting that I've dialed into, there has on the whole been recognition that actually we're dealing with a workforce who have given an awful lot over the last few months, and we've got to be very careful that they've still got reserve to keep going and to be able to look after them. So I think, you know, it is a valid point that we need to keep aware of. Particularly as more and more things get asked of them, you know, things around the COVID vaccinations, the extra vaccinations, the winter pressures, and the drive to keep elective activity going as much as possible. All of those things, we've got to find the balance, haven't we? It's a good point. Glynis.
Yeah, I was just going to ask about the potential increase in the demand for palliative care, and there's a list of risk factors, but I'm just wondering whether you are confident that they have been mitigated. That's page 62.
Sure. I mean, I think it's an ongoing process, it's fair to say. I think, and that's always a problem when you write a document like this, because it moves on when you start writing it to where it is now. So I know colleagues have been revisiting that all the time. And Joe, did you want to add anything more about recent conversations around hospices in particular?
Yeah, thanks, Jane. Yeah, I did want to pick that up. So we approved a couple of weeks ago, we approved some additional funding to hospices in recognition of some of the current challenges. So challenges are twofold. One's potentially around demand at the moment, but of course the other is around the fact that they will be seeing reduced funding. We know that they are seeing reduced funding through charitable routes as well. So we've agreed a temporary non-recurrent support to the 4 hospices around Devon. We though had a discussion yesterday at commissioning committee about the fact that, so I certainly shared some concern that was a number that we think will be helpful to them, but might only take them through a very short period of time, and we need to be sure that throughout the whole of winter that they are supported, sustainable, and we understand any risks, and if needs be, we consider back at the commissioning committee additional support, which we could, but that needs to be done on the basis of need of those hospices. So we've asked the team to do a very rapid bit of work, literally over the next week or so, to try and determine if any additional support is needed.
Thank you.
Thanks, Joe. I'm not seeing any more hands, but can I just then ask just a couple of questions, and then we need to look at approving this. One of my comments is the comment of a pedant, and I apologise for that one, and then a question about how this is bearing out in reality. So on the top of page 16, above 4.25, you've got a table that talks about DPT and Liverpool South West. I'm trying to think whether they mean the same thing, and if they mean the same thing, can we just use the same language? That's my pedantic thing. And then the bit about what does it look like in reality, you've got 5.7, the modelling that providers have come up with around bed occupancy and activity split, and 2 of those months have now passed. So what does reality look like compared to the modelling? And if it's not consistent, does that challenge some of the suppositions that we've put into this document that we're depending on?
Fair challenge on the I'll check the mental health one, Paul. I couldn't be quick enough to look at the chart, but I'll check that offline. But the in terms of so these demand and capacity figures within the document obviously were part of our phase 3 submission, so obviously done back in September. So obviously they were have been locked down, and I am pretty sure that we will be seeing a very different picture to the reality in terms of what we've experienced in September, October, and that needs to be, and that's what we want to particularly do, is track through on the urgent care board. The impact of that, of course, will be felt in our phase 3 recovery trajectories, and I think we'll be seeing those numbers coming through, and I think that comes back to the heart of the challenge of this winter, is how we can ensure that we can still recover our elective activity, and of course the risk and the consequences on our waiting lists.
Thanks, Jane. Joe, you wanted to come in.
I'll just pick up. I was also not quick enough to pick up the chart quickly enough, but I've just gone back and had a little look now in terms of your question, Paul. So those numbers, I think your question was about why are they different?
No. The question was around the language. Just if they mean the same things, use the same language. That's why it's pedantic rather than anything else.
Fine.
Okay, and we may well pick up some of the how we're getting on with phase 3 plans compared to reality when we get to the performance and quality report later on today. Okay, so some good questions. I think, Jane, it feels like a really comprehensive paper. So thank you for putting that together. There are so many strands to what our winter plan should be like normally, and even more so with all the added complications that we're seeing at the moment. So thank you for that.
Can I just sorry, Paul? Can I just particularly want to acknowledge Alison Wilkinson and Lauren Benham on this, because they put a huge amount of effort in. So
yeah, all right, thank you, Jane. Yes. So we've been asked to recommend it, to approve it, and what I would say is if we approve it, that says we will be supporting and wanting our organisation to play its part in delivering this, because as James said, it's only as good as the delivery. So that's a statement of intent as well as an approval of paper if we do so. So I'm looking for hands. In the absence of hand, I'm going to assume you approve. And I get no hands, and that's either because we approve or because my technology is not working. I'm going to assume the former, and Jane, that paper's approved. Thanks very much for bringing that to us and the work involved. Timetable says a break. I think it's probably quite good just to get up and stretch our legs briefly. We're ahead of time. I'm going to say it again, we're ahead of time because I so rarely get to say that when I'm chairing a meeting. And let's get back at 3 o'clock for the finance report.
SG, come up here. Come here, darling. Good boy. Come here, sweetheart. SG.
Right, so hopefully people are coming back into the room. I can see Sheila and Glynis, and I've heard Gaynor's dog, so I know Gaynor's here.
Sorry.
Simon. Oh, Simon's hand up to say he's here. Excellent. John Dowell, I hope you're here, because 8.1 is your item, and that's the finance performance report, and we're asked to note the month 7 performance. John, do you want to talk us through?
Thank you, Paul. Yes, I'm here. Welcome back. So the report in the pack, which starts on page 80 of the papers, as Paul said, is the finance report for the periods to the end of October. The reports there I'll take as read, and happy to pick up any questions on the detail. Just a few words of introduction, which are slightly different this month than previously. Just a reminder that for the first half of this year, we were in the emergency financial framework that was put in place to cover the COVID response period, which effectively was working on a method of initial allocation and then a process of retrospective reimbursement for costs incurred for dealing with the COVID pandemic. There's a full exposition of those costs on page 94 of the report. A total of 45 million to date has been incurred, of which all bar 7.6 million has been reimbursed to us already. The 7.6 million we expect to receive reimbursement for that. It's still going through the final checks with NHS England and Improvement, but we've no reason to be concerned about the risk of that. So that will see us get through to the half-year point with an overall break-even position. As we've said in the introduction to the report, for the remainder of this financial year, then for months 7 to 12, we move back to a position where we, as an organisation, have a fixed allocation, and we're expected to manage our costs, including the costs of dealing with the COVID pandemic, within that fixed allocation. So we are now including in the finance report, as well as the monthly position, we've got a year-end forecast, which we will continue to revise through to the end of this year. On page 101 of the pack, page 19 of the report, in Appendix 3, we show an exposition of our financial plan for the rest of the year, the budget that we've set, and our recorded expenditure against that plan to the period to end of October, and also a year-end forecast. That year-end forecast that's in table, sorry, I gave the wrong page number, it's page 88 if you're trying to find it. The table in there shows a year-end forecast adverse variance of just over 29 million. Just to clarify that, the one element of the expenditure programme which is still reimbursable outside of the fixed allocation is the continuation of the hospital discharge programme. So we still have recourse to reclaim those costs incurred by ourselves and our local authority partners from NHS England by retrospective reimbursement, and our forecast value of that for the remainder of this year is the 29 million figure, which will continue to map again through through until the end of this year. So on the assumption that that is all reimbursable, and there's no reason to be concerned about that assumption, it's that takes us back to an overall forecast break even for the CCG. The other risk which we identify in the report is a 6 million risk in relation to the commissioning of work through the independent sector. At the time of writing, there was a financial risk associated with that, which was on the assumption that commissioning and payment of work going through the independent sector would be passed back from central commissioning of NHS England Improvement to local commissioning for the final quarter of the financial year. We now know that that's not going to be the case. It will continue to be nationally commissioned for the rest of this year. So that identified 6 million risk has been mitigated because it won't be passed back to us. Those are probably the only points I needed to clarify, Paul. Thank you, but very happy to pick up any questions.
Thanks very much, John. That's very comprehensive. Any questions or comments for John? Sheila.
Thank you. Teams is very slow today, Paul. I'm sorry for the lag. John, bear in mind that governing body made a commitment towards equity shares for the Western locality. Probably a year ago we made that decision at governing body, and I can't see in this report where that would come from. Would it come from contingencies?
That's right, Sheila. So just a bit of explanation around that. The commitment that we made at governing body to make a shift in respect of equitable consumption of resources, the plan that we had set in the pre-COVID period, the 5 million recognition for that we made was indeed to come from our contingency. As the pandemic hit and the emergency financial regime was put in place, it's made it difficult to fully respond to the 5 million challenge because that source of funding was removed. But we have been working with local system to continue to develop the plans that we want to take forward, and we would still expect to be implementing some of that, I think, in the final quarter of this year.
Excellent, thank you, John.
And Simon.
I'm just intrigued to understand more about this early discharge scheme, John. It's obviously something that's now continuing or planned to continue to the end of the year, and I guess simultaneously we're now doing continuing healthcare reviews from the 1st of September, so that those are picking up the ones that have been, I guess, supported already on the early discharge scheme, and there's a continuing process for that. Do you think this is a transition to a new way of funding discharge from hospital?
I don't think it's a transition to a new way, Simon. I think it's a temporary arrangement. There's two aspects to the scheme that are continuing for the remainder of this financial year. So anyone who was in receipt of a package from early discharge from the first half of the year, we can continue to reclaim the cost of that package. For the second half of the year, it's slightly different in that the recourse to central funding is only available for the first 6 weeks, whilst an assessment has to take place, and then the ongoing cost of care will either pass back to local authority, or in the case of CAC eligibility, it will come to the CCG. I do think that's a transitional arrangement, though. I think once we so on the assumption that we get back to something more like normal in 21-22, I think that central funding stream will stop and it will be back to local responsibility.
Okay, thank you.
Thanks. I can't see any others. John, you may not know the answer to this, but it's just started this year just as things were sort of hotting up, but we haven't got our normal sort of, the cost savings plans that we would have had to have in place as a CCG. Many of them are beyond our control given COVID, but things like our running costs, our primary care prescribing, some of those other elements, where are we compared to where we thought we might be able to get to this year? And the reason I ask that is because it will give us a sense of where we start April 2021 in. just to get a sense of, are we starting from a position of strength, or are we looking at quite a challenge when the next financial agreement comes through for the next.
Yeah, thanks, Paul. So I think the short answer is we will start 21-22 with a challenging position again, no doubt. To some extent, the announcement from the Chancellor yesterday confirming additional funding for the NHS will be helpful. There's quite a lot of unpacking of that to do before we understand exactly what that means in terms of the allocation that we've got for the population of Devon. So there will be some help in there, I think, but we will undoubtedly be returning to a position where delivering against those savings programs and finding efficiencies within the wider system comes back into play. And just to give a sense for that, which I think we do cover in the report, as we came into the COVID period, we'd set a deficit plan of 47 million, which required 20 million of savings and efficiencies in order to get there. We won't have made the progress with those savings and efficiencies that we would have wished to because of the operational circumstances that we've had. So, but we can assume that we're going to need a programme of at least that magnitude again from 21-22 onwards.
Okay, thanks, John. That's helpful. That gives it sort of the wider context, which is right, because we can live in a 2021 bubble for a little while longer yet, but it is just a bubble that we'll have to move out of at some point. Thanks. Any other comments or questions? Otherwise, it was for noting for governing body, so we note the report, John, and thank you very much. So that is then on to item 8.2, which is the performance and quality report. Jane, are you starting us off on this one?
Yes, I'll start and then bring in Darren, if that's okay with you, Darren.
That's fine, Jane.
Okay, thank you. We have worked to try to make this report more integrated in terms of the commentary around the issues raised. Obviously, we want to go further on that journey, but that's certainly our intent. In terms of highlighting a few areas under the performance constitutional standards, we have data up to the end of September, and we've also got some data here supplemented on our weekly unvalidated data that helps us have a better snapshot of performance. In this report, we've also included, for the first time, our performance against the phase 3 trajectories, which I'll come on to. In terms of cancer waiting times, obviously, as we've previously discussed, our performance on the cancer waiting times through the first wave of the pandemic was stable for everyone's hard work and effort and the use of the independent sector to protect our cancer activity. September performance against the 62-day standard sort of held up, broadly speaking, against the overall target. That is variations across providers. But what we are now seeing, and of course have subsequently seen, is the challenge in terms of our COVID activity and then the pressures in relation to theatre capacity, diagnostics, etc. So we're starting to, you'll see particularly that it comes out in our 2-week wait performance as shown in this report. And I think that in essence has been an area which is a particular focus we're looking at the moment in terms of the symptomatic breast standard performance, which is subject to a deep dive, which we agreed at the performance committee to take to the next quality committee for review. And I think what we have here obviously is the increase in demand, as well as the challenges as related to we've been discussing previously around staffing, sickness, isolation, sub-isolation requirements, as well as challenges in diagnostic capacity. Our adapt and adopt programme obviously is quite pivotal to addressing that performance. I think the report is around the elective care in terms of our waiting lists. As you can see from here, as expected, the rise in our total waiting lists increased just by 4,000 in total, and 854 in terms of our over 52-week waits. In the report, it just shows the ophthalmology and orthopedics being the majority of our long waiters, and And obviously that is a particular focus of our surgical restoration programme, looking at productivity in terms of numbers of cases treated on list, but looking at best practice, etc. But what we know, of course, this is where the biggest challenge is in terms of ensuring that of any risk in terms of potential harm through lengthening wait, and making sure that is managed by our providers, our trusts, through clear risk stratification, prioritisation and review. There is a national e-review programme where all patients are reviewed, and that starts in mid-October, aims by mid-December to at least every patient have had the first initial contact to ensure that patients' priority are being checked on and being reassessed. But obviously that is a major area of focus and assurance that we are continually seeking in terms of making sure that risk is appropriately managed. In terms of diagnostics, we've obviously, as previously reported, we know that's been an ongoing challenge, particularly challenged by the COVID-19 first wave. Saw some marginal improvements in relation to in September performance, but of course the comparator to the national 99% target, we are obviously significantly below at let's see the number jumping up me now at 68.3%, which is broadly in line with the England position, but a major challenge. And of course, diagnostics is fundamentally crucial to our key cancer pathways. The report sets out the initiatives under the Adapt and Adopt programme. Some of them I've already referenced. The use of the independent sector is absolutely crucial, and as John referred to earlier, we are now for the last quarter of this financial year moving on to a framework agreement funded nationally, but we will set the contracts locally. There are some changes into that model in terms of it brings back into place a cost and volume contract arrangement, and obviously independent providers are able to undertake their own private work. So we're in negotiation with those providers at the moment around those contracts to make sure that we can have as much flexibility as we can have to support our elective restoration programme. But it is a risk that we're obviously having to mitigate against. We have a much less flexibility than we had in the first wave. I think probably I'll just move on to urgent care. Obviously, since this report obviously reflects on the September position, but we've known obviously in recent weeks the COVID increases of activity and the challenges that's placed on our providers in terms of ED through flow through the hospitals in terms of loss of capacity, and that of course then impacts the response in ED in terms of managing the numbers coming through. We've seen obviously any attendances have been increasing since May, but still in October figures 28% lower than previous years, and certainly with the lockdown that we're in at the moment, we've seen that drop continue. But we are, even with that reduction, we are below the national 4-hour standard for the trusts that are reported against that. It doesn't report, UHP does not report against that standard. We have, I see that really is a consequence in large measure to the challenges within the hospital to flow people through in the loss of beds that we've been experiencing through restricted access due to COVID patients and outbreaks in hospital. And I think I will probably ask, if it's okay, Darren, to ask you to do the update on 111.
Yeah, thanks, Jane. So from a 111 perspective, I think what we're seeing over there is a slow but steady improvement in performance. I think we need to be really mindful of the 111 first impact, but ultimately what we are seeing is a positive increase, and mainly due to the workforce impacts. So seeing continued increases there. Overall, we continue to work with them very much around the focus around reducing call abandonment. So they are now reporting Devon doctors at the national average, but call abandonment, we are working to continue to support them to achieve the 5% target. And also the other focus for us is very much working with the team around the eliminating of comfort calling, because ultimately if we get those individuals triaged appropriately, the comfort calling will not be required. So good areas there. I think also linked slightly back to the urgent care, Jane, is very much, we are continuing to see high breaches, particularly in terms of 12-hour breaches. Ultimately, what we know that is not good patient experience whatsoever. So we are working particularly with the Western system around how we look at some far more system approaches around there. So end-to-end case reviews to really understand the patient experience. We're not seeing significant harm, but it's definitely not good experience. So working very much with SWAST, University Hospital, Plymouth, Primary Care, etc., to do a whole system approach around those particular breaches. That's probably all I'm going to say on 111 and urgent care. I'm happy to pick up a couple of quality issues, Jane, if you finished.
Yeah, that'd be great, and I'll pick up then the phase 3 point at the end.
Brilliant. Thanks. So just another couple of things just to draw the board's attention to. So as Jane's alluded to, that we are bringing this report much more integrated, but ultimately there is still some work to do. I think the bit for me that we are continuing to see much of the impact around, as we've alluded already to in the board this afternoon, is around the impacts on staffing, and particularly staffing absences and staffing resilience. So we do really focus on that. I think in terms of the COVID absences, we're now with the lateral flow testing being rolled out and good support across the system, that will start to mitigate some of those particular absences and the impact that is having on capacity, particularly for elective activity. In terms of a few other quick areas, continuing healthcare. So as I reported at the last board, we remain on track. Despite some of the challenges around those particular areas in large numbers, we're definitely on track to reduce and eliminate the backlog as planned by the end of this financial year. And then just in terms of the wider infection control challenges, there is an ask of all of our providers now to ensure that they expedite the flu campaign. So traditionally those have run to the end of December, probably into January in many cases. But with the COVID vaccine on the horizon, the expectation is now that all of our providers will have completed their campaigns by the 7th of December, if not the 14th at the absolute latest. And we're working in terms of the assurances to get highest compliance as possible in those particular areas. And then the final area for me is, as we have seen high numbers of, so 250 individuals now with COVID positive in our acute hospitals, what we're also seeing is the non-sequelae and asymptomatic spread. So again, making sure that we work as a system to make sure that we are working collectively with best practice around infection control procedures and making sure we're learning from areas where we're seeing reduced areas. So good system working again. Back to you, Jane. I think you might be
on mute, Jane.
Sorry. Yes, to conclude, in section 4 is our first time that we've reported to the governing body against the trajectories for the phase 3 recovery. Obviously, this is looking at the activity-based trajectories. They're set out at the bottom of page 11 of the page 12 of the board pack. And we have and this is based on, I have to say, draft data, because obviously this is on the weekly data information up to the end of September, the performance against those trajectories. And that's basically, obviously this is a different way of looking at our information compared to obviously when we looked at the constitutional standards. So this is obviously comparing our activity compared to previous last year's levels, and each trust has set a proportion that they can achieve against the obviously set out national ambitions. And this chart here is showing where we're in line with that plan, or where for the month of September, or where we are off plan. And I think it's fair to say it's we need to look at the further to refine this reporting, and obviously would welcome any comments that we can actually to make this as useful as possible for our colleagues. But it gives you a sense of the overall position and the month of September. But obviously, as we've positioned all of this performance, very cognizant of the fact of the impact of the recent weeks of increasing COVID activity, and we'll be modelling in terms of understanding what it's done in relation to our position in terms of this performance and the trajectories that have been set. What's in the paper also is some of the particular areas to note in relation to that, and I think probably just to highlight just 2 of those. Referrals were in excess of planned volumes, 117% for September. and our day cases and inpatient elective recovery rates were in line with the trajectory for the month of September. And obviously we'll be looking at that very carefully for October. I have also, so I should say at the end, I'm very conscious that our focus hasn't really embraced in any detail in our discussions around the mental health performance. So what we've listed in this report, just a summary of the phase 3 plans. We haven't got all the populated data in yet, but just to give a sense of how we'll be looking at some of the key activity measures in terms of access across mental health. Thank you.
Thanks, Jane. So any questions or comments whilst I'm waiting for hands to come up? I mean, we can understand some of the pressures that we're under, and therefore some of it that's playing out in that performance report. I guess it's the cancer 2-week waits, and it's the particularly things around the breast symptomatics, where we're seeing quite a significant drop, and that's a concern because the risk of harm in there is quite significant. So I guess it's just a question, first of all, what's our process of monitoring potential harm as a consequence of those particular pathways? And what's in place to try and protect those? And can I just ask for a point of clarification? The table on page 12, where you look at our current performance, our CCG figures are different from our STP figures. Can you just explain why that is? What are the different things that they're looking at, just to help me understand that table?
So I'm just trying to find that table at the moment.
Shall I answer the harm review question first?
Yeah.
So where we are with harm review, so we've now got a system-wide approach where we've got some peer reviewing in there as well to try and minimise the clinical activity. I think also from a cancer point of view, we've got a well-advanced cancer network harm review process, so that we have a monthly report, particularly around the priority 1, priority 2 cancer weights and any particular harm. And what we are trying to do, and it is working relatively well in some of the small specialities, which will now roll out further, is to actually be far more proactive. So not just reviewing at the end when potentially we know that harm has happened or not happened. It's about the risk stratification through a number of points in the patient journey to make sure that individuals that then may need to be prioritised or stepped back up. So it's not just about harm reviews. This is about a much wider risk stratification approach for our medium and long-term waiters, and particularly our cancer patients.
Okay.
And building on that, Darren, is also the conversations that we had earlier about the dynamic decision-making group is the requirement for each trust already has a cancer clinical prioritisation group, and it was that what led UHP requiring some mutual aid support because we had some time critical cases that were being counselled. So those arrangements there. I think what we have to do is take those arrangements to the next level, particularly around outpatients 2-week wait considerations as well.
Yeah, no, I would agree, Jane, because like you say, in reality, we've got some really good examples where mutual aid has worked really well. So particularly UHP going into Cornwall with their surgeons and undertaking theatre activities, that's really positive. But like you say, these are small numbers, and actually it's much more about the 2-week wait and the outpatients that we now need to take the learning to.
Absolutely. And I think in answer to your question, Paul, about the table, I will double check, but I'm pretty sure it relates to the fact that the STP is relating to all our provider numbers. Our CCG should be relating to our population, whereas the provider numbers will reflect their total workload, which may include out of CCG residents. But I will go offline and I will double check that, but I believe that's correct.
All right. Okay. And it's probably thinking about how we express that. STP should be what represents our population, not necessarily what represents our providers.
Indeed.
It's one to consider the messaging that then gives if that on that table. Okay, all right. If you can take that offline, Jen, that'd be really helpful. Alison.
Yeah, thanks, Paul. There's one line in the report that says the overall serious incident position remains positive, apart from Devon Partnership Trust. And I'm aware it may have been discussed at Quality Committee, but could someone just update us on the current situation?
Yeah, absolutely, Alison. So I would say that in reality, even the Devon Partnership Trust position is much improved. So I think we've been very articulate about the backlog, particularly with DPT. Devon Partnership Trust. We are now down into less than 20 outstanding serious events that are over their original due date. The quality has also improved, and we're working with Devon Partnership Trust. But what we've heard this week is that we will be down to 5 outstanding serious incidents by the end of December. So I would say, from their perspective, that's a very positive position going forward. But also, what I'm really sure about is the quality of the learning that's coming out of those reviews.
Yeah, that's the important bit, isn't it? Is what we're going to learn.
Absolutely.
Okay, thank you.
Yeah.
Thanks very much. John Walmsley.
Thanks. So we just started to touch on the subject I wanted to explore when Jane and Darren were talking about mutual support. So we're looking at RD&E. They've had trouble maintaining the type 1 A&E for our waiting time, and trouble with detox coming out the other end. So trouble getting in, trouble getting out. Do we record and how often mutual support, mutual aid is asked for? And do we record whether it's asked for early or late? There's no doubt we're becoming a much more supportive system. And I think how we enact mutual support could be a sign of how well we are doing and whether we need to do better. And I suppose if it's been enacted an awful lot, then it might be an indicator that maybe parts of the system need to be even closer than they are now. So mutual support would be interesting.
Okay, I can a couple of points on that, John, is there's been a sort of formalised process for mutual support for some time in the system and being used. Obviously, we're taking it now to a new level, in relation to the dynamic decision making group, but also there is, particularly in the SEND area, very tactical mutual support going on, from twice daily calls being undertaken to see how they can support the 3 hospitals in terms of challenges and flows. And obviously at the 3 times a week dynamic group, all the trusts, UHP included, acute trusts, are involved, where we're trying to look forward a bit in terms of mutual aid. So I think you're absolutely right. It's a very much a developing agenda. It's good to see that development, and it's needed in the context of the challenges that we face. And the decision-making framework approach that we've put in place that's risk-based will help us document that decision-making where it takes place on the more I would say next week decision-making rather than on-the-day decision-making tactical work that colleagues are doing at the moment.
So I'd ask the governing body whether that's the sort of thing we want to be coming to the board. It is a sign of how well the system's working. So I was surprised and pleased to hear that NDHT supported RD&E by taking some patients. I mean, that's great. I hadn't heard about that. And I think it would be good to have a report at some stage as to how well the system is working together. I don't know how you do that, but I can leave that with you, Jane.
Okay, will do. And just to clarify, yes, I use the word SEND, and for the purposes of this, it's the South East North Devon system in terms of that geography, just to clarify.
Yeah. Lovely, thank you.
Great, thanks, John and Jane. Simon Kerr.
Yeah, I think collaboration is a really good thing to highlight, John. But I think too often it takes a crisis for us to really look laterally. And in general practice, we looked laterally, didn't we? And we suddenly thought, let's do e-consult, let's do digital monitoring of patients to try and relieve the HR constraints we've got in general practice. So, what is the system doing? What's the CCG doing? What are all acute trusts doing to try and look perhaps around the country and see what other systems are using to use digital to help them manage, maybe Think First or Think 111 first. Is there an e-consult version of that maybe that can help to divert people that doesn't necessarily require workforce? Could we be using more of the digital solution to help support a need to maybe not have a face-to-face outpatient or follow-up outpatient consultation? What other sort of systems are we putting in place to try to help manage this performance, knowing that even when we don't have COVID around, we've got a sort of demand capacity match problem in Devon?
Well, certainly the application of virtual consultations is obviously significantly in place in relation to hospital-based appointments. That already has been very much adopted, and obviously is built into the trajectories here in terms of looking at face-to-face and non-face-to-face. But I think there is always more to be done, isn't there? And I think how we work across our system in communicating and using technology in relation to managing pathways. So for example, the work that's underway on the cancer work, the more that you have that joined up electronic capability, the easier it is to make those arrangements happen in real time in terms of supporting staffing gaps that may exist. I don't know if any colleagues have got any particular examples that they can share on that we have in place.
Do you want me to come in, Jane? It's Jo.
Yeah,
just because one of the things you mentioned, Simon, it was think 111 first. So so just to be helpful to know, so it's an example, but I think a really good example of where I think some of the secondary care consultants are thinking quite differently now. So we've agreed a pilot for basically online consultation from ED consultants. So if the disposition is through think 111 first, particularly relating to injuries is the first area we're going to pick up. If that's the disposition, we're going to do a trial with RD&E to understand actually what can an ED consultant do in that space over video. So we're doing that, and we're hoping that will come back to the board in the next couple of weeks. I think there is some real positive moves out there.
I was just thinking of how easy it was for me to do an e-consult this week myself, and there's a lot of minor injury that you could do through an e-consult module as well, I guess. I don't know whether that exists or whether that, but bee stings is something that very frequently turns, or stings or bites, they turn up to minor injury units, they turn up to ED. That should also, or most of that shouldn't require a clinician to have to handle that, because a lot of that could be handled remotely through a digital platform, I would have thought. Those sorts of things I think we need to be really using to the maximum effect in Devon.
Yeah, and I think that's a fair point, and I think what Joe's describing, I think there is a journey that clinicians who aren't used to dealing with people remotely will need to go through in the same way that primary care has, and it sounds as though starting that with A&E through some of that 111 first route that Joe's talked about is a good way to try and test that and try and see whether they can apply their clinical expertise through the remotely. So I think it's one for us to keep revisiting and keep high on the agenda. David.
Yes, thanks. I was just Darren said that he was expecting flu vaccination to be completed by the 7th or at the latest the 14th. I'm assuming he's not talking about vaccination of the 50 to 65 year age group, which will be coming up presumably whenever the vaccine arrives. Yeah. And I suppose my bigger question is, as far as I understand it, we cannot vaccinate with COVID within a period of time after flu. So I'm just a bit concerned about overlapping the two campaigns, that we won't be able to give both vaccines. And I've heard that it's 2 weeks, but I'm willing for someone to tell me I'm wrong.
I think Sharon, that lands very neatly on that, doesn't it?
Yeah, no, absolutely. So yeah, apologies, David. So obviously I was referring to the staff vaccination programme, not the wider 50 programme. So apologies for that. Yeah, and in terms of the COVID vaccine, we're at the moment, there are some conflicting information out there, I would say it's fair to say. And until we get absolute MHRA confirmation of the characteristics of the vaccines as they're approved, we can't say definitely, but ultimately it will be somewhere between 7 and 14 days, more likely to be the 7 days between a flu vaccine and the COVID vaccine. But so we're very dependent on the MHRA characteristics approval, but 7 to 14 days will be the difference between the two. And then obviously a further COVID vaccine 28 days after the first.
Yeah.
And is it fair to say, Darren, that the first priorities will be around NHS staff, and hence there's been the real push to get NHS staff flu vaccinations as high as possible, and then the clinically extremely vulnerable who should have been in our first tranche to vaccinate for flu. So the same priority groups almost apply to both, and so there should already be, for the majority of them, enough of a gap for the COVID vaccine to be given.
Yeah, you're absolutely correct there, Chair, with the latest guidance.
Thank you. Thank you.
Thanks. Nick Kennedy.
Thank you. Just a question about the private sector provision. Clearly, that's been reduced now for various reasons. Have we done everything we can to try and convince them to make as much available as possible to the NHS? Because I know some of the providers would much prefer to be doing private work only or nearly only. And is there any national pressure on the private sector to help the NHS at the moment, and what can we do to try and improve our capacity there? Or is there anything we can do? Have we tried everything?
I think it's ongoing. There's good relationships in place. John Finn's leading this work with his team in meeting. They meet with all the providers each week, and obviously the framework is, well, it may have come out today. It was expected on Monday, which is what we would basically call off from in terms of the contracts that we would set from the 24th of December, because the current national contract finishes then. And obviously our aim is to maximise as much capacity and as much flexibility to support where we know we have the needs in relation to our demand and waiting lists, etc., working with our providers. So it's an ongoing piece of work, but certainly the framework has been set nationally, and we have to work within it. It is not as flexible as it had been previously. And obviously we have to work within those arrangements, but obviously looking to push it as far as we can, obviously with a goodwill and good working relationships with our local providers.
Yeah, it's just, I think that some of them, particularly in Exeter, I think there seem to be no desire to do any of the NHS work, from what I understand. I don't know if that's right.
Well, I think that's the challenge. The framework allows them to undertake their own work. And of course, business principles would apply, wouldn't it, in terms of the. But at this point, unless it's come in today, and John Dow might be aware, we don't know yet what the tariff that has been set nationally and how good that tariff is compared to obviously private work. But I would have thought it will be lower. So that is the challenge we've got, and risk for the last quarter, because obviously our phase 3 plans obviously have a significant predication on the independent sector capacity.
So thanks, Nick. I think that's the fair point. Let's just be careful. There will be stories, or there'll be new sense of what we hear about our partners' appetites to support us. But let's test that and find
exactly. We've got good working relationships with them, so that's what we will want to push to the max, really.
Yeah, I guess that was the point. Thank you.
John W. And then I think let's move on to the next item.
So Joe, just go back to 111 for a minute and think 111 first, and that side of that sort of service. I've heard some clinicians voice some concern that although the theory is great, this might increase workload in ED departments rather than decrease it. So is part of the assessment going to be that we're going to do a clinical review of the appropriateness of the disposition of patients? So how good is a service at signposting individuals to the correct service? Because if everybody's signposted to, say, the ED department, which takes pressure off general practice, that may be great for general practice, but not very good for EDs. So are we going to have a clinical assessment of the disposition side of things or not?
Yeah, thanks for the question, John. I think it's really important, given that we're going to be going live at the end of this month on the service, just to clarify some of the messages that are out there at the moment, or certainly some of the narrative that's out there at the moment. So just to be really clear, so the pilot sites that have gone ahead before us, most of those pilot sites are showing a reduction in ED attendances. At the very worst, they're showing flat. So we've seen that data. So that, first of all, that gives me a good level of assurance. Second thing is, in terms of when we've trialled the additional clinical triage that we're putting in place through Devon Doctors 111 service, we've seen an increase in the percentage they can validate. So take ED dispositions as one of those. That's gone up from 44% to 84%, and the percentage within which then are being their disposition is coming out as ED has reduced. So I also feel confident that our local service is having and will have, when we go live, a positive impact on ED. Also, I think what would be helpful to say, so we've got a couple of our GPs sit on the Think 111 programme board, and certainly the work that they've done and the conversations they've had with the LMC locally, there isn't a big fear that this will result in any significant increase into primary care either. So there will be some patients who currently would attend ED services that would be more appropriate for primary care, and they may then choose, and we hope they will choose to use Think 111 instead, unless they go to somewhere else in the first place. But actually there are appropriate patients that should be going into primary care, and actually when you look at the numbers, the impact will be fairly small.
So we need some good comms around this, that actually all parts of the system are aware of the reality of the service, and there's no sort of inappropriate negative vibes going around the place. So I think regular updates would be important.
That's a really good point, John, I think.
Okay, thanks very much.
And I think helpful just within our public meeting, just to reiterate something that we as a governing body spoke about earlier today, which was some of the concerns we're hearing from primary care about the impact of Think 111 first. The primary care committee have agreed next week to consider those, and actually I'll ask, because I know that Julie as chair is there, as part of that, considering therefore what is the comms plan that we should have in order to try and mitigate, first of all, some of those anxieties, but also some of the risks should they become a reality. Okay, thank you. I'm gonna move us on. We've spent a good time on that, so that's been really helpful. Thank you, Jane. Thank you, Darren. Two things I just want to say. Firstly, I think the way the report presents is really good. It focuses our mind rather than a wealth of data, which is there if we want to read it, but actually just concentrates us on the key issues. So thank you. I think that's really helpfully laid out, and particularly because we will be monitored by NHS England on our delivery of the phase 3 response. To have that included as well is really useful. So thank you. That format I found very helpful. The other thing that people mentioned a couple of times in questions was around collaboration and how essential that collaboration is. There is, so we've had a couple of papers earlier in today and then also within this meeting where we've approved a way of working, particularly around winter and around COVID, that requires collaboration. And Jane, you yourself said that actually it's about the delivery, and so a means of monitoring that delivery will be an indirect way of monitoring our system's ability to collaborate effectively. So I think there is a mechanism there for us to get a sense of that degree of collaboration by whether or not, or how effectively our plans that we've discussed today actually come to fruition. Ginny, I'm going to hand over to you now for item 9.1. So this is the updated EPRR framework that we're being asked to approve.
Yep, this is our high-level EPRR policy, which is one of our statutory policies, which is why it's come to governing body. We update it annually. You'll see from the track changes that there have been hardly any changes this year, even though obviously the policy has possibly been used more this year than previously. So it's just had a few tweaks and updates in line with a few changes to other policies. So the framework policy sets out our roles and responsibilities within the organisation, how we oversee things like business continuity, and also our role in overall EPRR assurance for the system. Obviously, the document is underpinned by a vast range of protocols and procedures which set out how all these various functions are delivered. So it's just a very high level policy that's come to governing body for sign off. Happy to take any questions.
Okay. Thanks, Ginny. Any questions for Ginny? It seems like a fairly straightforward and easy to follow, and a document that seems should be non-contentious for us as an organisation. So I will take it, lack of hands raised, I will take as approval. And we'll take that as approval. Thank you very much, Ginny.
Thank you.
So we now move on to our committee chairs reports. There are 2 actions for governing body, one from audit and one from quality. Otherwise, for commissioning, finance and primary care, I will take those as read, and that will then also allow us a bit of time, because we always run out of time to look at the locality updates. So that will give us a bit of time to look at those and still finish on time. So audit committee chairs report. Nick, welcome back. But the recommendation for governing body was around concerns that the assurance framework was not currently fit for purpose, and for governing body to agree the strategic objectives. Is there anything you want to say around that?
Well, we just want the governing body approval to keep the current assurance framework, whilst it is not fit for purpose, live until we've got the new assurance framework properly developed, because it puts us in a very weak position to have no assurance framework. So we just want governing body to confirm that the organisation is still working to the existing assurance framework until the new one is ready for approval by GB.
Okay. And do we have a sense of time, and that may be something for Ginny, of when the new framework will be available for us to consider?
So it's absolutely dependent on the development of the corporate objectives. So the assurance framework is our high-level risk management of our strategic objectives. So as soon as we get those strategic objectives agreed, we can put together the assurance framework and bring that back.
Okay. And we did some work on that this morning. So Andrew, when do we think, so I'm just trying to work it through, so how long we have to have an assurance framework that is deemed not fit for purpose but essential to have one in place, just trying to see how long we have to continue in that environment. So Andrew, to the point where we've got the corporate objectives that allows then an assurance framework to be written around them?
I think it's just a matter of a couple of weeks, Paul, so if that helps Ginny with the timeline.
Okay.
So it should be possible to have the new assurance framework ready for the next board, I think.
Okay.
I think that may, sorry, I think that may be a push if we've got another couple of weeks till the corporate objectives done, because papers for the next governing body will need to go out in a couple of weeks. So it's probably the January meeting if we actually need to do the work around sort of mapping all the risk around those objectives.
Okay. So our board is a week early. Our governing body is a week early in December.
Yeah. Okay.
So that probably does push it a little bit out of range. So you're asking us to keep the current ones in place, let's say for 2 months, until governing body can review new objectives and the new assurance framework in January.
Yeah.
Okay.
Thanks, Paul.
So again, I'll do it by hands. Hand means a lack of hands means we support that. And there's a lack of hands. Excellent. Thank you very much, everyone. Thanks, Nick. So Quality Assurance Committee, although it says that there are no issues to raise with governing body, it's purely the fact that you have updated your terms of reference that we just need to get those signed off in governing body. Glynis, anything you want to say about that?
No, just that they were considered at the meeting and approved, and so we're asking for governing body to sign them off.
Thank you. Any key changes in the way that Quality Committee will conduct its business that comes from these changes that we should be aware of, Glynis?
I think we've expanded the definition of quality to include the Care Quality Commission's 5 domains. So previously it was the Darcy definition. Now that's been expanded to include the CQC domains. And I suppose the other thing that's changed in there is that there's a greater emphasis on patient experience, and the patient engagement panel will report through the quality committee to the board in future. I think those are the main things.
Those seem eminently sensible changes. Any comments or questions for Glynis on that? And then are we, so again, lack of hands would mean approval of those terms of reference for the committee. Thank you, we take that as approved. Okay, thank you. And we'll take the next 3 committee reports as read. And then let's do spend a few moments going around our geographies. So I've got the Northern Locality Report first. John, are you going to speak to that?
Yes, okay, I can start off. So I'll take the report as read. I think what I would add is that it's been very encouraging the way what is actually a relatively smaller part of our system has responded well to COVID. It is very collaborative. And I think it's very innovative and working well as a local team. So I'm pleased by that. Importantly, as you see in the report there, our integrated delivery group is starting to function quite well. We do need to have a good data set, some intelligence, some information to work from if we're going to, first of all, have a self-regulating system. Where we can look at how well we are performing and look at what we want to change. So I was pleased that we've had some extra support from the central CCG function. So looking at that data set, and hopefully as the months go on, by the time we become, I suppose we use the term live come April 21, we should have a good data set in place. There's no doubt that population health management is going to be a significant part of how local systems assess the present state of play and allow some work to take place around what needs to improve and change to reduce health inequalities in our local system. The other thing which is not in the report because it just sort of started in the last few days is that our HIP2 initiative has started. So we were one of the 40-odd trusts, that NDHT was one of the trusts that has given some funding to look at how it's going to develop plans as part of the health infrastructure program. And part of that is going to be whether our buildings need to be looked at and altered slightly, whether we have the right digital format, and whether our services are as they should be. So it's a very forward-looking perspective process that I think having the funding to do that and giving clinicians time to step out of the day-to-day challenges of delivering care to think about how to improve it as the next 5, 10, 15 years go on is actually it's a luxury, and I think as an area we'll make very good use of that. And the last thing is that we are looking at our urgent care system and how that stretches both from 111 to GP services to ED, and how they're all linked and how those different parts can support each other, and how we can have a good directory of services that allows systems like 111 to direct patients to the right place at the right time and see the right clinician. So that there are no barriers to this work, which is good to be able to report. I think people are working well together, recognizing the challenge, which is largely workforce at the moment. And obviously there are financial challenges as well, but largely workforce is something that we're looking at. So that's all I was going to say. I don't know whether Andrew or Charlotte would want to add anything, and then we can take any questions.
So Andrew and Charlotte. Andrew?
No, thank you, John. I think you summed it up brilliantly.
And Charlotte, anything to add?
I was just going to ask, and I meant to ask you this, John, and forgot. With the PCN doing the homelessness work with the startup funding.
Yep.
What's the ongoing funding situation for the?
Oh, well, that's a very good question, Charlotte. That's startup funding, and we're not quite sure yet where that's going to come from. That is initiative through One Barnstable and part of our One Northern Devon work, and to get it started is going to be great. I'm not quite sure and clear yet how we're going to take that through into 21-22. We had that down as something we want to look at and address as part of our funding requirements for 21-22. If we're talking about the One Northern Devon programs, which is our collaborative group, then we're looking at something like over £200,000 that we're going to be looking at how we access funds. In the past, we've done that through the Improved Better Care Fund, and Health and Social Care have been very supportive of this collaborative work. So we're hoping and expecting that with a small arm twist, we'll get equal support for next year. Of course, IBCF doesn't exist in its present form. I don't know whether John Dowell can give us any indication of how that funding might be available for next year. But I have every expectancy that we can find long-term funding.
Okay, so we're not gonna let's not try and solve that or make any promises within this governing body. It's a commissioning governing body, so let's keep our commissioning hats on. James W.
Yeah, I just wanted to back up what John was saying about One Northern Devon, and to also highlight that it has received national recognition by way of an award as well. That's made it into the media recently, so great collaborative work.
Thank you, James. We are finalists for the award. We haven't been awarded anything, to be clear. We're finalists for the award for the HSJ collaboration section. So fingers and toes crossed, and we'll see what happens.
Excellent. All right. Thank you, John. Simon, we're moving over to the east.
Yeah, thanks, Paul. So I think the messages coming out of the east at the moment really is just trying to get through really quite significant demands in the acute trust with respect to the COVID impact. We continue to have weekly Eastern Locality Delivery Group meetings, which are multidisciplinary meetings with the acute trust, mental health, social care, and certainly last week it was the main discussion topic was planned care, but there was significant discussion obviously around the impact that COVID was having on the number of wards that were impacted, number of staff that are absent, and a lot of shared understanding with primary care and secondary care around that difficulty. We continue to meet with that group, as I say, weekly, and we have a rolling programme of themes of community mental health services, prevention services, urgent care services, community integration. And I think what we have achieved there is a much closer relationship between all those different parties within the locality, which is building opportunities to create pathways together, which is quite exciting, something we haven't done really as constructively and easily in the past in the east, certainly not perhaps as constructively as they've done in the north over the months. There are some quite significant concerns beyond that, though. We've got the RDE making proposals to change services in Morton Hampstead, which is causing concern for local practices there, which we put in the items of risk. And I've got reports from GPs around difficulties they're having with the transition to the acute trust using My Care, particularly around discharge summaries not arriving on time and discharge summaries arriving partially completed. So we've been trying to create some assurance for those GPs and also communicating that back to the acute trust. They have two ways of feeding back to them. They have a risk management site, which the GPs are asked to refer any items of risk back to. And they also have the yellow card scheme, which of course the CCG uses, so GPs are encouraged to use both. And I understand from recent comms from the RDE that those issues are improving, but they're ongoing issues of concern that we will be keeping a close eye on. I think other than that, there have been some active work on trying to develop a leg ulcer service, enhanced service for the Eastern GP practices, which some of you will be aware of. I wasn't able to be part of the discussions on that at the Commissioning Committee because I've got a conflict of interest there, but I know that work has been going on, and that will be hopefully a significant advantage to those people struggling with leg ulcers in the Eastern locality at the moment. That will hopefully go live fairly soon. And I think there's a lot of work going on with one of my colleagues, Dr. Andy Wood in Exeter, working with Adam Rubin around the Think 111 First activity that has come out of the Eastern Locality Delivery Group. The other thing I ought to mention is the re-emergence of the ELF Forum. So that's the higher strategic, if you like, local care partnership executive forum that is being reinvigorated, and there's another meeting on Friday this week, which unfortunately I won't get to, which will be chaired by the Chief Executive of the Acute Trust. And that will be, I hope, further exploring the, I think, useful meeting we had a month ago, where again, it's about how do we work together, what are the values that we share, what are the behaviours that we share, and how do we work as a wider system together, looking at the population health management data and what population health management will tell us across the sizable locality that we have, so that we can ensure that the ELDG group, which is a commissioning operational group, focus on the right areas to make sure we deliver better outcomes for the locality. So I think that's a sort of brief summary, Paul, of where we're at. But I think the message to get across is that at the moment, both in primary care and secondary care, the staff are really working very hard just to manage the COVID outbreak.
And John Down, Glynis, anything to add to what Simon has said?
Okay. No, there's nothing from me.
No. Okay, all right. John W., your hand's up.
So Simon, thank you for this. I wasn't quite clear from the report why the proposal from RD&E around the change service is either a risk or a concern. Because there's lots of very positive statements there in the report saying it's going to improve access, improve equity, that side of things. So was it around the fact that maybe not enough people were involved in the redesign of the service, or what's the actual concern around that?
I think that this is the service around Morton Hampstead Hospital, John.
Yeah.
I think that was concern from local GPs, that they see their what they see as fairly difficult access to community teams as it is, being even more difficult because some of those staff will be moved even further away than they currently are. Large geography, and I think that I had personal communication with 2 or 3 of the GPs from Morton Hampstead to say that they felt that their services were going to be undermined by that move away from the hospital.
Okay, thanks.
Okay. So thanks, Simon. Let's keep moving. Let's head south. David. It sounds like an adventure. Well, we're tier 3, so we're allowed to move around the county at the moment. So let's keep going. David.
Thank you. Yeah, the report is as read, but I just wanted to raise 4 issues. The first one is about personnel. So I'm sure most people already know that Derek Blackford is now the Associate Locality Director. And he's starting to get to know everybody. He's starting to arrange one-to-ones. So it's great to have somebody there to help us with our work. Second thing I wanted to raise was about COVID. Just to say that the good news for the South is that hospital admissions and number of patients with COVID in the hospital has pretty dramatically reduced. We've gone from over 40 to low 20s in terms of people in hospital. So maybe the lockdown's working, I'm not sure, but something is driving that down. Second thing on the COVID is that within Torbay, the ERC is hopefully going to be the vaccination centre. The council have been talking to the PCNs about that.
Sorry,
which would be a fantastic
ERC?
English Riviera Centre.
Okay.
Where
the palm trees are, John.
All right.
Yeah. Except that, and this is something I would be interested to know if other people have come up against, CQC have communicated with GPs to say that premises where large-scale vaccinations are going to be given would need to be registered with CQC. So that's just a question for other GPs whether they've come across this. But I'll wait to hear what people say. Third thing I wanted to just raise was about LCP. I'm aware that in the South we probably have lagged behind other areas in the development of the LCP, but the LCP delivery group is back meeting. and they had a productive meeting last week. And I think things are starting to move forward again. So I'm much more encouraged than I was a few weeks ago about where we were on that. And finally, just to talk about the enhanced care in care homes, all the practices are signed up. And again, I just wanted to highlight one of the things that encourages me when I think about working together is the Torbay Care Home Visiting Service, which is going to take on that service for the whole of Torbay. That's 3 PCNs working together to produce a care home visiting service that will deliver that service. And it's involved a lot of cooperative working, particularly in terms of 3 PCNs pooling some of their employed staff to work within that service, and also agreeing to pool all the money that comes in for that service. Right, any
Okay.
open?
Thanks.
To...
Well, let's just ask Jane and Judy whether there's anything they want to add from the report.
No.
Okay. Simon.
Yeah, thanks, Paul. Thanks, David. So it's on the personnel front. So I know there's been a bit of noise around leadership in the South locality. And I just wanted to remind people, really, if we reflect back, Sove Sanson was the locality director and secured employment with Devon County Council about a week before we went into lockdown. And then because there was so much pressure in DCC, she actually went without working any notice, so it didn't give us an opportunity to thoughtfully recruit. So as you've said, Derek Blackford is fulfilling the role on an interim basis, but I have now got agreement from both Torbay Local Authority and Devon County Council to go out to advert for a joint appointment. It will be our first joint appointment with Torbay Local Authority, and I think that's really good news. I'm still in negotiations with the Director of Adult Services of Torbay about what resources will go in to support that locality director, but we'll get there. It's every journey starts with one step, doesn't it? So we're moving forward. And just on the LCP front, and this is sort of a general issue, because I was supposed to be at Easton tomorrow, Simon, but I've got a day off. But I was at the Plymouth LCP this week, and also the South locality. So I think there are steps forward. The delivery groups are really important. I know they're looking to try to get, or Derek particularly trying to get the South locality delivery group into a bit more of a coherent group, because I think it's grown a lot, hasn't it? Got quite a lot of people on it and quite a lot of priorities. I think there are about 17 meetings hanging off that group, so he's going to try and rationalise that, quite rightly too. But one of the things we've been discussing at all the LCP meetings is leadership, because there is a set of recommendations that have come out from the development leads led by Philippa around what the leadership needs to look like over the next 6 months, which will go to the partnership board on next Wednesday. And that's certainly forming part of the discussions that we've had at the LCP groups over the last week or so.
Thanks.
Thanks, Simon. And just a quick hello to young Master Millward, who put his head round the corner then before his dad unfairly turned the screen off. Just before I bring in James, Sonia, just I think is it worth just clarifying, just because we're in a public meeting, the numbers of people currently in the trust beds, not necessarily just within the actual Torbay Hospital?
Yes, of course. So obviously we have a situation where some of our community hospitals still have COVID positive patients as well. And in South, Brixham is a designated care setting. So although the numbers in the acute wards are coming down, and rightly so, quite a few of those are being discharged to community hospitals. So if we take it in the round in terms of where they are, those numbers, albeit they're coming down, they're probably not coming down quite as quickly as, David, you were led to believe.
It would be great actually if the daily updates just highlighted that fact so that we can be clear.
What we're trying to do is just make sure that the trust is consistently reporting with national standards and the other providers. So we're rectifying that.
Okay. Thanks, Sonia. That's really helpful. And yeah, let's make sure we've got consistent reporting, and so we know we're comparing apples with apples will be really useful to be able to do. James.
Yes, thank you, Chair, and thank you for the report, David. I just noted there seemed to be a considerable number of key priorities in the report for the next 3 months. And I just wonder, given the current situation and winter pressures, whether that might be considered a little overly ambitious.
So I think probably what that reflects as much as anything is a lack of clarity of leadership. And hopefully now we've got Derek coming in, I think he will shake that up and we'll be under considerably more discipline to actually focus on the most important things.
Thank you. Great, thanks, David. Okay, so last but definitely not least, we head west. Sheila.
Yes, thank you, Paul. So first of all, I'd like you all to admire the streamlined, cut back, pared back Western locality report after Nick Ball and I took a pair of scissors to it last week because it was getting rather long. And in particular, James, you might be pleased to see that our list of priorities is relatively achievable, I hope. So the key things that I'd like to pull out are, first of all, the ICP procurement, which of course is a major piece of work and is requiring an awful lot of staff and resource. The fair shares, which is alluded to there, that's also another piece of work which is of great importance, as you know, to the Western locality and to our GPs and PCN clinical directors. There is a project which is referred to there, it's called I Cope, it refers to frailty, and we have managed to so far introduce that to the Plymouth LCP, where it's been favourably received. There are still some questions and some streamlining of that needs to be done, but we are hopeful that we will be able to take that to a commissioning committee before too long and get that signed off, which would release some investment as was intended by governing body into the Western system. The Plymouth LCP is well into its stages of development, but perhaps I would like to just raise a concern there about the Western LCP, which you may notice, and I have to confess I have just spotted it myself on rereading it, is that this report is very Plymouth centric. And I think that probably reflects the fact that the director's name at the top of this is Anna Coles rather than Joe. And I think we probably do need to sort of reflect on that for our next report and more practically actually reflect on how we're going to make sure that that does get reported through to governing body and in particular get some progress report on the Western LCP development. And then finally, I wanted to just comment on winter pressures, which of course are with all of us, but feel very real and very pressing in the Western locality. And there is some positive news though. So the COVID hot hub continues. It's a good example of collaborative working by those GP practices that have chosen to use it. It's got a group of very proactive, very motivated GPs who are still working with Elaine Fitzsimmons and with David Jones, our urgent care commissioning team, to make sure that we use the best, that we can utilise them as best we can to support the local system. And finally, the other two things I want to draw to your attention are that there are early signs. I know there are only early signs, but the numbers of inpatients in UHP of COVID patients hasn't continued in line with what we expected and what was forecast. Make of that what you will. I'm not willing to say anything at this stage, but I've got my fingers and toes crossed. And finally, that last week, the national team was down looking for mass vaccination sites. I'm not sure if I'm allowed to say what the outcome, in fact, I don't know what the outcome was. I know there was one site that was favoured in Plymouth, which we're hoping that the 5 of our PCNs will also be able to use. So that could all come together quite nicely, but it's progressing, I believe. Okay, enough from me.
Thank you very much, Sheila. Nick Ball, in fact, your hand's up. So I was going to say anything that you wanted to contribute, but you may want to contribute, but also there may be a question or comment you want to add in. So over to you.
It is a question, really, Paul. I just need, as the NED representative to the West, I need a bit of clarity, please, about at what level are non-execs now currently supposed to be involved. So I and Sheila were both a member of the LCP boards prior to COVID. Then the Plymouth board was suspended because of COVID, and I understand it's now been stood back up, and I've just been dropped off the membership list, and so is Sheila. I've never had any communication from anybody to tell me about that. So I was actually, until last week, I thought that the LCP was still stood down in Plymouth. So I just would like a bit of clarity. If non-execs are not required to be part of the LCP boards, then how do we get involved in the localities? Not necessarily for answering now, but I need an answer.
Yeah, so I think that's a really good question, Nick, and I think there's a difference between LCP now, as in local care partnerships, and what we would have called our local commissioning partnership before. Unfortunately, care and commissioning both begin with the same letter, don't they? So that might have caused some of the issue. I can tell you that the Plymouth LCP, as in local care partnership, met on Wednesday. So it was Tracy Lee, Anne James, Adam Morris, myself, and Pete Lehman as the collaborative board chair, and was then attended by Anna Coles and Joe Beard to help support as officers to help support that. And we had an accommodation, we had an estates presentation, but also a couple of others around community mental health framework. So I think that's a question for the partnership board about how LCP, local care partnerships, will include non-exec, layperson or patient representatives included in its makeup, because I don't think that's been adequately addressed. In terms of our commissioning work, I think there's still mileage in us making sure that the locality director, i.e. our employees, are linking appropriately with the NED and clinical lead for that area, but it might not be with other partners. So I think that needs clarity, Nick. I agree with you, but I think we need to ask the partnership board.
So what I would say with that, Nick, is we've got a system NEDS development day coming up, and I think that would be a good forum in which to have that conversation, because it's relevant to us. It may well be also relevant to some of the provider organisations as to where you get that non-executive oversight within an LCP, and worth having within that forum, because Susie will be chairing that. And I think that would be a useful place to have that wider conversation that then may form some sort of process that that's taken through to the partnership board. So I will have a conversation with Susie to ask her to include that as one of the things that we consider when we come together. Judy.
Just commenting on that, thank you, Paul. I think it's really important we establish a principle about non-executive involvement rather than just leaving it to each partnership board to maybe decide it will and maybe it won't. Can I just say I would like us from our next meeting to have a report from the West locality and call the Plymouth one, so that from the very beginning there's no suggestion that we are treating West as a lesser body. I appreciate we talk about localities, but as Simon just said, what's happened is this has ended up being Plymouth's report. So I don't yet have any of the details about what the arrangements were or are, but I think it's important that the CCG treats them absolutely equally to everyone else.
So, Judy, I think that's a really valid point, and the way we report on our geography should reflect the way in which we operate on our geography, and we're going to be having to do that more and more on LCP footprints than on our previous locality footprints that we had for the CCG. So one of the things that I'm going to be taking up, and clinicians, GPs, apologies that we've not talked about this earlier, but we will definitely pick this up, is moving towards LCP reports coming into governing body, and how we make sure they feed through, and the involvement of our locality directors as part of that. And also the question to make sure that we have enough oversight, make sure, do we do 5 every month, or do we do it on a rotating basis, in order to make sure that we have enough in-depth awareness of what's happening in each local area, but not necessarily the frequency that we currently have. So I think that's a conversation we need to have, but definitely let's make it reflect the way in which we are going to be doing business, which is over the 5 local care partnerships. Simon.
Yeah, can we have a longer discussion about this? So one, I think as a CCG governing body, we can definitely make a recommendation about lay member and non-exec involvement in LCPs, but it's not solely in our gift to do that. And the way we're looking to set up our management structure will mean that because I don't think, and hopefully you would support me, I don't think it would be appropriate to have a senior manager at the same level as we do in North and East and in Plymouth for West Devon of 85,000 population. So our plan at present, because it is coterminous with Devon County Council, is for that to be run out of the South Devon and Torbay office, but with a manager that sits in Western supporting that post. The other thing I think is really important is there will be a lot of overlap with the Plymouth report, because the Plymouth report will undoubtedly talk about urgent care in university hospitals, Plymouth, or community services provided by LiveWell. So we just need to make sure that we're not asking people to duplicate, but we're only picking out the really key bits that is independent to any of those LCPs.
Yeah, absolutely. Yeah, and it's part of a wider discussion, but what we discuss here, what we hear here, has to reflect the work that's going on within our geographies, and there needs to be some line up to governing body of the commissioning involvement within LCPs, and so it's making sure we've got a structure that appropriately reflects that. So we're not designing it now, but I think that's got to be the overarching priority on how we make sure that the sort of reporting that comes through. Yeah. Nick.
I would like to absolutely support what Judy said. I think the important thing for our governing body is that we establish a principle and we apply the same principle across all LCPs, rather than think about the individual relationship with the individual LCP boards. I think we should make a statement about what we believe to be the right level of involvement. And actually, when I raised my concerns about the West, I was more concerned about the fact that Sheila's not involved than I am about myself, because, where's the clinical lead at the LCP board is, for me, a bigger concern than non-executive involvement. And my second point was I was going to be in danger of getting into the details, so I won't make it now. But I think you're right, Simon. I think having a longer discussion about this would be really useful fairly soon.
Okay, thanks, Nick. John.
So Sheila, I'm glad your report was cut down, because if it had been longer, we'd be here all night. So I'm glad that. So Simon, you're right. We need to talk about this more. There's a lot of things to discuss here, and I was just going to ask Sheila, when you mentioned David Jones's input to the urgent care discussion, sometimes I find local GPs get confused as to whether they're a commissioner or a provider. I feel that we should have GPs who just give a clinical opinion. Do you find that there are the same challenges in your general practice workforce as to whether they represent general practice as a provider or as a commissioner? Is that a problem that you find?
Yeah, it depends on the individual. There are some people that are very good at making the distinction, and there are others probably less experienced who really struggle with it. So yeah, it's something that actually, you know, brings me on to something completely unrelated to this, which is about an induction for new GPs who've started, because we are employing, you know, we do take new clinical leads on. We've taken one on for learning disability very recently, and I think supporting them to think like a commissioner doesn't just, you know, that doesn't just happen by osmosis. It needs quite a significant amount of support. Yeah. I did have my hand up, Paul. May I?
Yeah, carry on.
Yeah, I just wanted to go back to the LCP discussion because I wasn't aware of the decision to run the Western LCP out of the South. And I might, in fact, I would like to have a view on that. I don't know what my view is at the moment, but so far it's not I'm not thinking that it's positive. So we've got, you know, a group of Western GPs who are already feeling disenfranchised, who are now going to be not contacted by and not managed particularly well by a Southern person. And what's my role in that? And this role here that I'm in now is supposed to be linking in with the LCPs. So I've already been disenfranchised from the Plymouth one. I have no idea what that role is going to look like. At the moment, my Western LCP report, you don't need to worry, it'll be very short indeed.
So let's take there's several emerging elements here around local care partnerships. So there is the issue that Nick Ball has raised, and let's make sure we've got places for these to go. And Nick Ball has raised about non-executive input and oversight at local care partnerships. And I think that is probably somewhere to discuss with Susie and with non-executives from across the system as to what that should look like. And again, it's about setting a principle as a system that then gets applied appropriately within each locality. But I think there is a good forum for that to sit. There is definitely something around clinical leadership within an LCP. And I think that we play a part in that, but not wholly. And I think that's something to talk to the development leads of the LCPs along with clinical leads both at system and locality level. And then the other issue is about the management structure to support those LCPs. And I think, you know, Simon has put together a proposal, a plan. I think language is important. So if you have someone who is responsible for the South and the West, they are equally responsible for both, rather than the South person covering the West. And I think that that's certainly something that we would want in the way that we approach this. From the outset of developing the West Local Care Partnership, we've been clear it would have equal importance within the system and within the CCG as any other local care partnership. So let's just make sure, you know, let's make sure we describe it in that way. I think that's really important, not just for the GPs, for the population there. And I think it would be good to have a development time to think more about what that means for us as a CCG, or when we bring all of those elements together. So here's probably not the time. I think we need a bit more space when we're a bit earlier on in the day, with a bit more, we're less tired and more able to focus on it. But Simon, you wanted to say something?
Yeah, so just very quickly. So one was a response to Sheila, and one was a suggestion. So I can't ask, and Craig's been very clear, I can't ask Anna to provide the senior leadership for West Devon LCP because she's a Plymouth City Council joint appointment, so it can't be there, Sheila. So if we want somebody of the similar skill set and experience as Anna or Tim in North and East, it needs to be conjoined with somewhere. So, but I'm happy to discuss that. So my suggestion, Paul, was that if I work with a group of colleagues across localities and across both NEDs and clinicians to work up some options, proposals or discussion slides to bring back to the development session for December if we can. Would that be useful? Because I think that there's a lot of richness in this that we can take forward, and I wouldn't want to overburden my exec colleagues because they've got real jobs to get on with. So I've maybe got a little bit more space to be able to work with colleagues.
Okay, we do that for January. December's just a half day, and we've certainly got some important issues to fit within business within December, but we can certainly do that within January. But I think in parallel, we also have to have those conversations with wider system partners around non-executive and clinical presence within LCPs. Let's do both in parallel. I think it'd be really important to do. John and Sheila, and then.
Sorry, Paul, nothing me. That was just a lazy hand.
All right, and Sheila.
Yeah, just something to think about, really. Well, I'm just reflecting now is that the system has decided that we should have a Western LCP, but the system doesn't want to give it its very own director to lead it. That kind of is a bit, doesn't fit really. That clashes. There's a bit of cognitive dissonance there for me. So, you know, I won't say any more. I think I've said it all, really.
Okay, so I think I think there are perceptions here that probably need a little bit of clarification. I think let's get something together with a working group, and let's bring it back in January, where we can describe where decisions have been made and why,